All right, we'll go ahead and get started. I'd like to welcome everybody to the first Big Idea Symposium for Climate and Health. My name is Robert Tighe. I'm the director of the Duke School of Medicine Climate and Health Research Initiative. Really excited to have everybody here. As a way of introduction and opening, Dean Mary Klotman is going to give some initial remarks, and then we'll hear from Dr. Mary Rice. Many of you know Dean Klotman. She's the Executive Vice President for Health Affairs, Dean of the Duke University School of Medicine, and Chief Academic Officer for Duke Health. She's going to give some introductory remarks.
Good morning, everybody. First of all, I want to thank Rob Tighe and his team. Rob has been working with me now for the last couple of years to think about strategy around climate. And as you know, that started with the university a bold move, appointing a vice president, Toddy Stillman, for climate, and then cascading that theme throughout all of the entities across Duke, and also as part of the campaign. So this is one of those areas that we are completely aligned. Very often when we think of climate change, we think in terms of economy, the environment, but often we don't think in terms of, and yet whether it's changing heat, it's flooding, it's areas where water is rare. These are all threats to human health. And easy to put climate change and health together at a place like Duke. Because when we take on challenges as an institution, it's always, to me, so inspiring to see how many people come to the table and really think about how they can take their expertise and apply it to whatever problem are trying to solve. And that is exactly what we're seeing in our Climate and Health Initiative, that we are seeing both areas that are obvious, like air pollution and the impact on health, but areas that are not so obvious, near and dear to my heart, is the effect of climate and temperature change on the microbial environment, really the external microbial environment, and how that will likely impact the types of organisms that become human pathogens and real disease. So we are seeing that spirit really come together here at Duke around climate and health. We're at an exciting moment in science. One of, I think, shared frustration is that now is not the time to take foot off the pedal of science, that we have so many tools available to us today that will absolutely accelerate the rate of discovery and the rate of impact. And climate is certainly one of those areas. And yet we are dealing with some external forces that have kind of dampened some of the areas of work that will impact many of these areas of science. Nevertheless, I think it would be absolutely wrong to be discouraged or to stop applying our thinking and our action. Because, first of all, pendulum swing, we know that. But also we know that the way we position our science meet a lot of national priorities. And some of it is how we focus our science or some of the language we use. So one of my messages today is do not be discouraged. And frankly, as John Rawls and I were just talking about, some of the more catastrophic changes that would threaten our research environment have not happened. So I want you to keep focusing. I tell everybody that asks me, what can I do? I say focus. Focus on what you do well. And if you need help, we're there to help. But main thing that all of our faculty, staff, and students should do is really continue to apply their enormous skills. And applying it to the area of the intersection of climate and health is a worthy area to do that. I am excited by the response that we've had from faculty, also committed to providing certainly some funds. We were very, very fortunate. Rob and his team worked with the Dean's office to put in a very competitive proposal to the Duke Endowment that provided us with very, very important initial funds to get things off the ground. And what I know that works at Duke is if you put an RFA out for funding opportunities, everybody responds. And people ask me, well, you know, why is Duke always doing so well no matter what happens? And it is that part of our enterprise, that, you know, putting something out there that starts a cascade of activity, people coming together, collaborating. And so I am seeing that around our initiative in climate and health. I think it's incredibly exciting. So looking ahead, what we do in the School of Medicine is not independent of the campus. I think what defines, the unique part of Duke is the fact that we have a full campus and an international campus to collaborate with. And again, in this area of climate and health, I encourage all of you to look outside of your areas of research, look outside of your areas of collaborators, look on campus. Rob has represented us on many of the campus meetings, and there's enormous interest, whether it's in policy or the Nicholas School of Environment. Look for collaborations far and wide. Look in Duke NUS. What a great area to partner with our colleagues in Singapore around climate and health. So this is not only a campus-wide initiative, this is a worldwide initiative. And I am absolutely excited to see the response of our faculty, looking forward today and looking forward to what we do in the future. So thank you all for being here.
Thank you, Dean Klotman. So it's now my pleasure to introduce Dr. Mary Rice. Dr. Rice is the Mark and Catherine Winkler Associate Professor of Environmental Respiratory Health at the Harvard Chan School of Public Health. He's also an Associate Professor of Medicine at the Harvard School of Medicine. He's the Director of the Center for Climate, Health, and the Global Environment, or CHeRI. It is one of the longest-standing centers focused on climate in the country, which has been open for 30 years, which sounds like a huge amount of time. He's also a fellow pulmonary and critical care physician, and also a fellow environmental scientist. So her research is focused really on the impact of environmental exposures on lung health, with a focus on air pollution. He's also been an individual that's hugely advocating across the country and the world, and has held positions both as the chair of the American Thoracic Society Environmental Health Policy Committee, and also serving on the Clean Air Scientific Advisory Committee for the EPA before they decided to send everybody home and see who else would come. But I say that as somebody who has spent her career not only trying to look at science and the way that science is important for impacting human health, actually has also done the work to take that science and start to use it to influence the health of all the people that we care about across the globe. And so I thought that Mary would be an amazing individual to come and give us a keynote presentation. We're starting to think about how we take this work here at Duke forward with some experiences for what's been done at Harvard. So with that, Mary, would you come up?
Thank you, Rob, for that kind introduction. And thank you all so much for coming here today. It's wonderful to be here in front of such a large audience and to be talking about climate and health, something that is important to all of us and that affects all of us. My objectives in the next 45 minutes, and I hope to leave time for questions, is to describe some of the key pathways linking climate change and fossil fuel pollution to health. Because I'm a pulmonologist, I'm going to emphasize the lungs. And then I want to talk a bit about the experience of CDC. I've been in this role of director of this center for a little bit over a year, and a lot has happened during that past year. And I want to tell you about some of the ongoing research we have, education and engagement initiatives. And lastly, I want to open it with a discussion about the future, opportunities, potential strategies for building an impactful climate and health research program. Here are my disclosures. I didn't know Dr. Tighe was going to share so much about my different experiences. I am still practicing pulmonologist, and the experience of being on the Environmental Health Policy Committee of the American Thoracic Society for almost 10 years was such a formative experience for me. And my stint on the U.S. EPA Clean Air Scientific Advisory Committee was all but 3 months until we were all fired. A little bit of history. Warming effect carbon dioxide, that's not new science, and that's not controversial science. In fact, it was first described in 1896 by the Swedish physicist Svante Arrhenius, and it was titled "On the Influence of Carbonic Acid on the Air upon the Ground," in the air upon the temperature on the ground. And in fact, if we didn't have that greenhouse gas effect, the Earth would be uninhabitably cold. We actually depend on that greenhouse gas. But of course, because the emissions of greenhouse gases have continued to rise, now experiencing rising temperatures, and projected greenhouse gas emissions and the future warming levels that we experience are going to vary based on the actions that are taken. If you look at the current policies that are in place, we're on track to reach 0.8 degrees Celsius by the end of the 21st century. If you look at the pledges that have been made, we're around 1.8 to 2.1. And the goal has been to limit it to, ideally, of the Paris Climate Agreement, less than 1.5, or otherwise 2. We actually reached the 1.5 annual threshold in 2024. That was actually the first year that the global average temperature was 1.55 above pre-industrial levels. Now, the global emissions targets are based not on a one-year average. It's based on a long-term average. So there's still a possibility of staying within that target. Now, an important point is that sources of carbon dioxide, which is the gas causing global warming, are also the same as the sources of air pollution. The burning of fossil fuels, it's the burning of biomass that releases carbon into the atmosphere, and that burning also releases air pollutants, gases and particles that are inhaled. And we know a lot about the health effects of those air pollutants. And just to give you a couple of examples, in our own work in Boston, we found that kids who live within 100 meters of busy road, a traffic combustion source, have 3 times the odds of asthma compared to kids who live further away. And in adults, those who live closer to roads have faster decline in their lung function as they age, and the effect size is those within that 100-meter buffer is equivalent to the effect size of having smoked tobacco in the past. We know a lot mechanistically about how these particles that are inhaled deep into the lung trigger inflammatory pathways, epithelial lining, then causing cascades of inflammation that affect organ systems elsewhere in the body, such as the cardiovascular system. And it's not just the heart and the lungs. This is a report by the European Respiratory Society and the ATS on what constitutes an adverse effect of air pollution. And it includes not only respiratory disease, morbidity and mortality, lung cancer, pneumonia, but also endocrine disorders, type 1 and type 2 diabetes, high blood pressure, DVT, stroke, neurodegenerative disease, premature birth and lower birth weight. The bolded health conditions are all included in the global burden of disease. A little girl named Ella Kissy Deborah, and she died from severe asthma attack at the age of 9. Her death made headlines because it was the first time that air pollution was actually determined to be a cause in her death, and it was on her death certificate. I've heard her mother speak, and on autopsy you could actually see the soot from the London air pollution in her lungs. Now, air pollution almost never makes it into the medical record or death certificates, even though we actually know quite a bit about the relationship between inhaling combustion particles and mortality. Because everybody's exposed to some extent to outdoor air pollution. worse for a global lifespan than cigarettes or alcohol. It's surprising in some ways because it's invisible. But if you look at the slope between exposure and mortality, in this case, short-term exposure, in the U.S. population here, the slope is actually steepest, the lower exposure levels. And another way to think about that is the opportunity to improve life expectancy is quite significant, even at what seem like relatively low levels of exposure to pollution compared to what we've experienced in the past. So I've talked a bit about how fossil fuel combustion, pollution itself, is a health concern and related to climate. How else is climate change an air quality problem? I'm going to take you through three major examples. One is ozone. You know, there are a lot of ozone experts, ozone health effects experts. Ground level ozone is a component of photochemical smog. It's formed through the reaction of nitrogen oxides and VOCs in the presence of UV radiation. It is a very powerful oxidant and respiratory irritant. And climate models predict higher ozone levels as a result of the warmer temperatures. So because the formation of ozone is enhanced on hot and sunny days. That has the effect of delaying regulatory progress. So here in this example in California, it has the net effect of undoing, in some parts of the Bay Area, the effects of reducing the ozone precursor. Ozone, here's a cartoon by Jack Harkema, Michigan, on how ozone induces airway remodeling over time. It leads to an asthma-like phenotype. It also, at very high exposure levels, causes fibrosis in the lung. And here's some original research by Dr. Rob Tighe and his PhD student, Marissa Gutenberg, looking at how alveolar macrophages actually play a role in reducing ozone-induced inflammation in the lung. I've looked at it in terms of the air quality regulations and the thresholds for the air quality index. And I think everybody in this room is probably familiar with, when you look it up on your phone, when you look at the weather, you can also see the air quality index that aligns with air quality standards. And we compared green zone, which is considered little to no risk, to the yellow, which it considers to be within air quality standards, acceptable, but potentially of concern to high-risk individuals. And when we looked in healthy adults, there was a 60 milliliter difference in lung function, the yellow days versus the green days. 60 milliliters is something that would catch the attention of a pulmonologist if you kept seeing differences of that magnitude on the test. And importantly, there was no evidence of a threshold. The lower was always better. We found that those who were obese had twice the effect size of those who were less obese, suggesting that this is a susceptible portion of the population to the respiratory effects of ozone. And this has been borne out in mechanistic models as well, seems to be real. Another air quality example, the pollen season. Higher carbon dioxide levels and warmer temperatures lengthen and amplify the pollen season. It's longer than it used to be. Plant growth is faster with higher pollen counts. And there's even evidence that the allergenicity, the potency of the pollen, is greater as a result of these effects. This chart here is an old experiment of ragweed. And you look at the pollen production of the ragweed. Right now we're at 430 parts per million. And that would be between the second and the third bar chart of CO2 levels. You might say, oh, pollen, you know, that's not such a serious issue, health issue. Well, it's really common. About a third of the population has hay fever, a symptom of allergy. Many asthmatics, their symptoms are triggered by pollen exposure. It's one of the major reasons people visit their doctors, and one of the most common reasons prescriptions and asthma admissions. And there's even some evidence that it's linked to respiratory mortality. My own work, we found that it causes eosinophilic airway inflammation, even in kids or teenagers who don't have asthma. And the last example I want to take you through is wildfires, which in this part of the country, you are all very much familiar with the effects of wildfire smoke. You've experienced it. And as a result of the warming temperatures, much like the pollen season is lengthened, the wildfire season is lengthened. We have greater accumulation of dry biomass and increases the risk of these really large and destructive wildfires. I was part of an ATS effort where we wrote we pulled together a number of experts, clinicians, forest managers, a number of people here from the US EPA and NIEHS who are from this area. And we looked at the respiratory impacts of wildfire smoke and made some recommendations for research. And even though this is quite old now, that we called this 2019, the recommendations I think are still very much relevant in terms of what research gaps are and how we might go about addressing this problem. And just like the example of ozone, wildfires are eroding the incredible success story of reducing emissions of fine particles from fossil fuel combustion. So during the period of 1988 to 2016, here in the blue, we actually saw a significant reduction in PM2.5 levels across the eastern half of the U.S. But if you look at the northwest corner, it was actually, despite the emissions going down, PM2.5 levels actually went up, and that's largely a result of wildfire smoke in the northwest in Canada. And research since that time found that that purple trend has gone away. So wildfire smoke has either flattened or erased the downward trend, reversed the downward trend of PM2.5, and we're actually experiencing increases across much of the U.S. More than a third of the particles in the air nationally that we breathe, based on the EPA emissions inventory, is from wildfires. That smoke travels really far. We know it's very harmful for the lungs. There's evidence it's 5 times more toxic per unit mass for people with asthma than particles from other sources. And what makes it so complicated is it's a mixture that varies based on what's burning. And what seems to be especially toxic, and this is from research led by the scientists who are at the US EPA Office for Research and Development, that has now been mostly dismantled. They found that it's really the flaming plastics that burn, that's what our built environment is made of, that cause the most DNA damage, that are the most inflammatory. And that's exactly what the city of Los Angeles experienced a year ago. Terrible fire burning down homes and motor vehicles. PM2.5 levels were orders of magnitude greater than parts I showed you before. 480 micrograms per cubic meter in the Eaton fire. That's the equivalent of smoking 22 cigarettes in a day. Very hazardous. Wildfire smoke isn't just an air quality, but it also interrupts our ability to deliver health care, people access their health care, as do many other extreme weather events that are increasing in frequency as a result of climate change. Making it harder for us to treat our patients, making it harder for hospitals to procure the medications like IV bags to deliver care in our emergency rooms and our hospital wards. So with that quick overview of a number of issues in many of the ways, but certainly not comprehensive, how climate change affects health, I now want to tell you a little bit about the history of the Center for Change and some of the work that we're doing. The center was founded in 1996 by 2 doctors who were talking about these issues as health issues when nobody else was talking. And they've formed it to focus on the impact of climate change on human health. In 1996, they published an open letter that was signed by 400 doctors and health professionals from 30 countries. And it was a full-page ad in the New York Times to warn world leaders who were attending the Kyoto summit the health effects that they could expect if climate change were left unchecked. And if you were to read this letter, it would have been published today. They were really ahead of their time. In 2012, the center moved from the medical school to the School of Public Health, where it is now. And Gina McCarthy, who is the center director before me, she cleverly added the name climate to the center name. It used to be the Center for Health and the Global Environment, but if you add climate, the acronym of CHeRI. So we've been calling change since. Well, our goals are to be a global leader and a catalyst, solutions-oriented climate, pollution, and health research, with solutions being a key word that I'll get back to. And the other pillar of our mission is to engage students and trainees through climate and health education and research mentorship by faculty not only at the School of Public Health and the School of Medicine, but university-wide, much like the initiative that the dean I pulled together a bigger team of faculty. So this is sort of our org chart, and Amrita Sarma is a data scientist and epidemiologist. She's the deputy director. Around us in the light green are our support staff and our communication staff. And then we have 12 core faculty members, each who bring in a different discipline, and they're serving as team leads in their area of expertise. We have represented global health, nutrition, healthcare delivery, and emergency preparedness, pediatrics, home environment, capacity building, economics, health economics, implementation science, and biostats. When I think about the solutions-oriented research that we're conducting now and that I'm working to build and expand, it's in these 4 buckets. One is it's for individual patients. It's like, what could a patient and a doctor talk about in the clinical setting? Other is healthcare systems, emergency preparedness, sustainable healthcare. Third bucket is solutions for communities and cities that could be implemented on the scale of, say, urban planning. And lastly, national and global policy. I'm going to give you a couple of examples of work that we have ongoing. So for individuals, I am actually just finished the last participant visit of this trial 2 days ago. It's an air purifier trial for people with eosinophilic COPD. And I see this as a climate intervention. It addresses combustion-related pollution from traffic. It addresses wildfire smoke, pollen, microbes, and fungi. And we installed real or sham air purifiers in the home and left them there for a year. And now in the coming year, we're going to find out if it made a difference. We also did very comprehensive exposure assessment to look at what people are exposed to in their home environment. But, just one step back again. So the implication of this could be, so if we find a benefit, this could be something that a doctor prescribes that health insurance companies could cover as part of durable medical equipment, much like oxygen and nebulizer machines, for example. And Megan Rabuli, who's from this area at UNC, is a collaborator. We're doing work on healthcare systems, and I know that there's a lot of work here at Duke happening in this area as well. So we have partnered with AmeriCare to develop resources for frontline health clinics, give them guidance on how to counsel their patients around weather, extreme heat, wildfire smoke, hurricanes, floods. And we've done focus groups with patients to try to refine these tools, and they're now being adopted throughout the world, including by the Filipino healthcare system. We're also developing toolkits and resources to plan, to anticipate. We know there's going to be more storms and hurricanes. So we've worked to develop heat and smoke action plans for clinics and health centers. Things like identifying who are our high-risk patients that we're going to want to reach, and make sure we have a way to reach them when we need to, or who needs to come in for early dialysis who could not wait 5 days in the event of a big storm. We're doing work with the City of Boston and also with community partners around the world that have been working with our faculty for years. One of the newer projects in this category is our NIH-funded P20 Center. This was a proposal that we put together right around the time I was starting in this new role. And the center is focused on solutions for heat, interventions for heat stress in 3 very different settings. One of them is in Boston, and this is a headline from the Boston Globe. This was during the period when all our grants were frozen, and intervention in Boston was to test the impact of AC units that we were delivering to very high-risk adults who didn't have air conditioning, had chronic disease, served by a mobile health van. And then as the summer came, we suddenly had no funding. So we really had to scramble, and we did it sort of at half scale last summer. Now that things have opened up again, we're going to continue next summer. And we're going to the hardest to reach neighborhoods, and the hardest to reach people who don't see a primary care doctor, who get their health checkups. And we're partnering with communities responding to extreme weather, which is a nonprofit in Boston, Family Van, as I mentioned. The other intervention, well, the second of three, super different, but it's in Madagascar. And one of our faculty, Chris Golden, is a nutritionist and a planetary health scientist. And he's been working in Madagascar for more than 10 years, speaks the local language. And in southwest Madagascar, everybody's dependent on fishing, how people survive. And he's added this intervention where we're storing the fish that people harvest. There's a separate issue of the coral reefs bleaching, and he's got an intervention there. But the problem is when you get the fish, they spoil. So by being able to store fish for longer, you're addressing diarrheal illness and nutritional challenges that are exacerbated by climate change. And in South Africa, we have a cool roof intervention in a peri-urban setting. So testing the impact of really just painting the roofs white, see what it does to the environment in the home. We talked quite a bit, Catherine, about implementation science. And I myself am not an implementation scientist, but it is so clear that we need this to be part of our research. We can discover amazing things, and then if we don't implement it properly, you know, who cares if it doesn't actually benefit people? And so we have a community engagement core helping us support our partnerships with the community partners, very closely working together across these three projects is our implementation science and evaluation core. Sudha Raman is a social scientist who is leading that. And what I've also learned through this so far is it's got to start from the beginning. When you're planning the project, you've got to plan your research for implementation. All right, and then the last example I'm going to give around national and global policy. We are very fortunate to receive a grant from the Wellcome Trust, not linked to NIH funding. So we could take a bit of a deep breath that this project should not get interrupted. But it's a 4-year project where we're looking at real-world exposures to combustion, traffic, industry, coal-fired power plants, natural gas, developing better models to really understand the constituents of that pollution beyond PM 2.5 at a national level. I'm going to take representative samples of those mixtures, those real human airway cells, develop dose-response relationships, these different components in mixtures. And then we're also there's also a population-level science piece looking at the U.S. Medicare and Medicaid population and HCUP looking at hospitalizations. The idea is that we then, at the end, develop tools for decision makers, could be city level, could be state level, could be national, think about what the estimated health benefit would be of different types of interventions and tactics. Okay, so that was a bit of an overview of our research. Now I want to talk about the other stuff that we do, this research. As I mentioned, the center was originally founded mostly about communication. And the team that I joined really good about reaching out to external audiences and sharing our work and bringing in new perspectives. So I want to tell you about some of the different initiatives we have going on. So there's the core center, but the center also serves as a catalyst. And one of the things I really want to support, much like Rob, you described as a goal of this effort here, is to really catalyze research and collaboration across the university. We have 70+ investigators, medical school, the School of Public Health. Actually, every school of the university is represented, law school. And we organize monthly research seminars, know what's going on. We have a quarterly networking event where we feature one of our partners. Last one was with the Family Van. The next one's going to be with a Global Health Institute, for example. We provide media support for all of our faculties to try to amplify their work. And then we have a monthly newsletter just so people know what's going on. There's a lot going on around campus. We engage externally. I mentioned our partners in Boston. We're working with the Massachusetts General's Office that's doing a lot of interesting work around cumulative impacts of pollution exposure and trying to address injustices in exposure and inequities in exposure in the state to try to prevent new infrastructure, new industrial growth in polluted areas. We have many international collaborators. We're trying to be very engaged at the national stage as well. And one example is the COP conference. So the Paris Climate Agreement occurred at Paris when that conference was in Paris. Many of you know, every year there's a conference of the parties place. One in Belém in Brazil was all about adaptation. We organized a number of events to talk about the health benefits of mitigation. I think people can sometimes do that, and that's a near-term health benefit. All right. We have a new concentration that was launched in 2024 at the School of Public Health, and any student can receive this certificate in this concentration. So you can be a PhD student, you can be a master's student, and there's some core courses that the students have to take. There's a seminar series that they're part of. We had our first 9 graduates in last May, and we have a number of students coming in here. Cora Basu, who's one of our faculty, also developed a curriculum at medical school around climate. This is a little different. We have a high school program. Gina McCarthy started this. She said, we got to educate people earlier. You know, graduate school is too late. So we have a program every summer. It's 1 week where we bring in high school students in partnership with Putney Student Travel, and they meet our faculty. They develop a project, and we've welcomed over 400 to that program. Climate creators to watch. This is new for me. I'm not very savvy on social media, but we have an award that we give out every year for people who are putting out good information about climate and health instead of bad information. And we're rewarding that through this partnership with Peak Action. And we've already given out 60 of these awards, and they reach tens of millions of people. And when we talk about the future, I see this as a real opportunity, a different kind of group that we might want to engage in our work so they understand the science better. I've already mentioned we're very focused on translating the high-impact research to the audiences that need it most. We pitch research results to the media. We're engaged on social media platforms. And we discuss climate and health solutions at the local, national, and global stage. Here's an example of a panel that we put together with city leaders talking about how they address extreme heat everywhere from Jacksonville, Florida, to Chelsea, an environmental justice community outside of Boston. So thinking about the future, this is my own list of what's on my mind, what I think as center director, I really want to focus on, and I hope to inspire others to think about these ideas. I really think we need to move beyond identifying problems. There are a lot of problems that we have described very well at this point, and we need to start shifting to testing solutions. One way in which I'm planning to do this next year is we're starting a new postdoctoral program where the postdocs are going to evaluate retrospective actions, things that have taken place. Not going to be perfect. The real world is messy. But see if there was actually a benefit. If a city transitioned their entire public school bus fleet from diesel to electric, what were some of the barriers? What were the health consequences, if there were any, if we can test that, and then for the kids, for the neighborhoods? What about the economic side of that? There are interventions at the clinical level, state level, hospital level, city level that I really think we need to look at. So we can understand what works for whom and under what conditions. Another, I think, exciting part of that is it gives us stories of success, something concrete that non-scientists can, can understand, oh, they did that and that worked, and now how can we do it even better? I think we need more research in that, maybe less of a focus on modeling future or hypotheticals, although I think that all of it is important. I think we need to refine our communication and framing strategies. They resonate across audiences. So testing out nonpartisan messaging approaches. Third, talking about vulnerable groups actually sometimes makes people think, oh, that's not me. Using words like we be more engaging. Talking about the changing climate. Perhaps instead of climate change, which for some people has become a word that triggers. So trying to study that and do that and communicate more effectively. And engaging trusted messengers. So I mentioned those social media influencers. Maybe we could work with them and do some really effective communication. Clinicians need to be part of this puzzle. Doctors are key actors. We are the ones who are treating the health consequences of climate change. We're also trusted voices, and I think we need to equip physicians with evidence-based messaging tools. And I know work in this area is underway here. Long said that we actually need to talk to our patients about climate change. Just like we might say it's a really bad flu season this year, it's a really bad pollen season or a really bad wildfire season, and explain why that trend is getting worse as a result of climate. It's about telling our patients what's going on. This is not political. This is affecting them personally. And in many cases, there are things that they can personally do to try to protect themselves from those health effects. So I'm going to, oh good, I left lots of time for questions. So I want to end with an analogy about two addictions. Is tobacco use. In both cases, the evidence is clear now, they cause premature mortality. They're both seem to be a cause of cancer. The WHO has determined that diesel pollution is a cause of lung cancer. They're both triggers of asthma and COPD exacerbation. Both impair fetal growth, are linked to premature birth, babies. In both cases, children are especially vulnerable to the health effects of exposure, and some of these health effects are irreversible. They're going to last for the rest of their lives. And that means that actions that we take today can have benefits to children who are growing and developing today. And in both cases, powerful economic interests no doubt about the science of these health effects. In the case of tobacco, health messaging ultimately prevailed, right? Everybody knows that tobacco kills. Everybody think about fossil fuel use in the same way. No, right? I don't think we've won that messaging yet. And in both cases, there's constant rationalization about why we shouldn't quit, why that shouldn't be part of the solution vision for. I have hope, and I take a lot of inspiration from the history of tobacco and what the public health community did in collaboration with decision makers. If you think about smoke-free laws, actually weren't put in place to protect the smokers. They were put in place to protect the workers. They were put in place to protect the kids, everybody else who's involuntarily exposed to that smoke. And in the case of tobacco, it was medical science, it was public health research that inspired these very local laws. California and New York, it started in a few places. Before you knew it, it spread everywhere, right? These local policies were made saying you can't smoke here anymore. Imagine policies that said you can't burn fossil fuels here anymore, and put those things in place, start small. I think we can there are just a few really good, successful policies that work, make people healthier. I think it's going to inspire more success stories. Climate pollution poses a comparable risk, as I've shown, as tobacco when it comes to health. And I think that same pathway is available today. We think with robust scientific evidence, trusted health voices, and scalable policy, we can accelerate climate action. I'm so excited that you're all here today to think about how to do that. And I'm also happy that I left enough time for questions. So I look forward to further about it. Thank you.
Thank you for such an outstanding talk, and I appreciate you broadening the conversation beyond just the ultimate product of combustion, CO2, complete combustion, to the point of incomplete combustion in terms of particulate matter, and actually another issue would be the PAHs that are the incomplete combustion products. And the fact that every day we drive down the street and look at the cost of gasoline, the cost of gasoline is not just the dollars per gallon, but extend beyond that to health effects. Thank you.
Thank you. Well, I don't know if everyone read the headline, but the U.S. EPA just announced that they're going to stop estimating that the health benefits of reducing pollution and the health costs of pollution, and because of concerns about uncertainty. And there's uncertainty about the costs of reducing pollution as well. And experience has shown that oftentimes we've overestimated those costs. So that's interesting to see where that will lead. Fortunately, when it comes to air quality regulation, cost is not supposed to be part of the standard setting process. But I'm fully in agreement with you that I think the cost side, the economic side, is really important. And as health researchers, we don't really want to talk about costs. Most of us, but people care about costs. And healthcare utilization is extremely expensive. And so I think we need to do more work bringing in health economists to our research. Thank you.
Mary, thank you, as always, for incredible talk. I have two policy implication questions. One being that the EPA in the United States standard setting is still well above, more pollutant is permissible compared to the World Health Guidelines, right? The World Health Organization guidelines for particulates. I'd love your comments on that higher standard in the U.S. or that looser standard, that we enable more pollutants. And the second is, in the translation to policy for carbon emissions from fossil fuel use, particularly in the energy sector, what I noticed in Washington, D.C. is we have nuclear saying we're the clean option. And yet, as clinicians, we understand this waste. We still have little understanding of the legacy of the waste of that. How does that enter into your conversations as you're informing policymakers?
Your first question was the WHO standard versus the U.S. So yes, the WHO standard for PM 2.5 is 5, which is lower than it is in the U.S. at 9. However, Europe is they've just put in place new air quality guidelines. And generally speaking, our thresholds, where we're at now, are actually lower than many parts of Europe. And so I wouldn't say that we're behind when it comes to air quality standard setting. I'd say that we're on par with Europe, and the guideline is a totally different process how air quality gets regulated in the U.S. But the level of 5 was based on very clear evidence of health effects that go down to that level. Another discussion that's going on here in the U.S. at the national level is, should the U.S. EPA consider health effects below its established threshold? And historically it has in these cost-benefit analyses, actually, because it's clear that they don't go to 0 at 9, right? That's another piece of the conversation. I think it's important to point out that the evidence is very clear that that relationship continues down to very low levels. Your second question was about nuclear. I think my simple answer is I think it needs to be part of the discussion. There's a lot we need to understand about the risks, and there's new technologies that are coming out. So I wouldn't say absolutely no way we shouldn't look at that.
I had a quick question then.
Okay.
You know, one of the things you could appreciate, I'm sure, as you do, is sort of when you start talking about climate change and health effects, is that you focus nicely on sort of air quality and combustion. It's so many things, and I think one of the things that has been a challenge that I've seen is how do you approach such a big problem with so many things that it does. And I don't know if you have any thoughts or advice on sort of how you think about that to make something not only for the public manageable in terms of a conversation, but also as scientists to not get overwhelmed by the thought that there's too many variables, and so how do you make meaningful impact?
I mean, climate change is such a big issue, right? And I just basically talked about the air quality piece, a very large problem that includes water and nutrition and so many other issues, peace and war. And what I try to do is focus where I feel like I can have an impact. And so here's my slide about the stuff I want to focus on. So I think people, I don't think I'm the only one who thinks this way. I think most of us are most inspired to think about things within their own lifespan, right, that affect them personally or that affect their family. And so I'm trying to frame the research that we do around interventions that not only have long-term benefits, but also have benefits that can be articulated. That's not to say that we don't need to understand what the long-term trends are and what the long-term consequences are of our decisions today. But that's how I try to frame it, to sort of keep my head focused on things that I feel like I can do and that I can fix. Another example, in addition to the air quality and cleaner air example, is food. So methane is actually one of the most potent greenhouse gases. So in terms of bang for your buck for climate, if you focus on methane, you're going to do more to slow global warming than focusing on CO2, right? Because it's so powerful and shorter lasting. So it's faster benefits. The methane comes from cows, and so dairy and meat. And meat isn't really that good for you. That's my understanding. I'm a pulmonologist, but fatty beef, not that good for cardiovascular health. And so our plant-based diets, Walter Willett, one of my colleagues at the School of Public Health, has put together this planetary health diet that still allows meat. It doesn't say that you need to be a total vegetarian, but you reduce your meat consumption, you increase the amount of plants and fibers, and not only does it have a climate benefit, but it has an enormous health benefit as well. And the effect sizes of nutrition, healthier diets are huge. I mean, 30% reduction in the risk of heart attacks for a healthier diet compared to a regular, as the person would otherwise eat kind of diet. That's a lot bigger than the 15% effect sizes that I'm showing you for some of these respiratory outcomes. So I think that's another opportunity, something that can do today that's good for their health today. The health benefits are immediate, and there's a climate benefit.
I thought of like rural communities or like indigenous communities, and sometimes these communities can be ones that have this historical distrust of healthcare or might not want to go to the doctor. How have you guys gone about approaching those communities and helping them with interventions when you have that historical, trauma?
That's such a great question. So I can give a few examples, but they're not all indigenous communities, but it takes time. I think there's no way around building trust, understanding one another, understanding what concerns are of the community, because you might come in with some great recommendation and you think it would make them healthier, but it doesn't address the near-term concerns of people that you're trying to work with of any community, then it's not going to be effective. So Chris Golden, who spent his career working in Madagascar, it's taken him decades to build that trust. And that's how we're able to do this work in fishing villages that are very, very remote. So I think it takes time, patience, and you got to listen.
Thank you.
Yep.
Any other questions? And as a side, when you ask a question, if you could introduce yourself so we can also get to know people in the room.
Well, thank you so much. I'm Norman Wurzba, teach here too. My question is about economics and the relationship between poverty and ill health, and whether or not medical communities are doing much to talk about economic disparities as drivers of really poor health outcomes, and why addressing poverty might be a key element in addressing the health issues that you've put on play today.
Thank you for that question. The answer, I agree completely. There's, in the environmental epidemiology field, we're looking at air pollution. Most studies will control for measures of poverty. So I think it is clear that environmental exposures on top of poverty are harmful. But poverty itself is harmful for health through a number of different pathways, and also reduces access to interventions that you might be able to take to try to keep yourself healthier, like eating a healthier diet, for example, or exercising or walking in a park. So I think there's this intricate web there, and interventions that elevate social determinants of health, that address social determinants of health, can often address environmental exposures at the same time, right? So it also reduces the exposure if you reduce poverty. So yes, I think it's a huge part of it.
We're going to take a couple of minutes and just talk about the Climate and Health Research Initiative and some of the background, ultimately to help inform sort of where we're going with this and why we're focusing on what we're talking about today, and even why we're having this kind of event. And I hope to provide a little bit of structure to what eventually will be a series of talks by projects that have already been active and ongoing, and then ultimately lead into the big ideas that we're going to talk about in the second half of the day. So we're a small but mighty group. So I'm the director of this research initiative, and Dr. Catherine Stanton, who is floating around, she's in the back there, is the co-director, and so partners in crime. And then I should have said this earlier, but I will say this now. None of this actually would have been pulled off today without Sally Taylor, who single-handedly keeps us on target and is amazing at pulling together a nice event like you see today. So Sally could stand up for a second and we could all acknowledge her. All right. So Mary Rice nicely put this out, so I'm going to skip through some of this. But to think about sort of from a broad perspective, but this informs sort of why we're thinking about this. Obviously, temperature rise is sort of one aspect of this. I think when we think about stuff locally, so there are these local things that are happening to us in North Carolina and the Carolinas that are really a reflection of these global events. And so they reflect local things, but also I think why we need to focus globally on our message and our understanding of the health impact. So even though we think about Canadian wildfires are a problem for North Carolina. And why is that? That's because the weather travels here. So as the weather travels here, we get smoke. Not smoke that we created, but smoke that comes down. And so it doesn't respect borders. It doesn't care if there's differences of opinion between countries. It's going to affect us all. Same thing is true when we think of large water events. So Hurricane Helene, which was supposed to be a sort of nothing tropical depression, somehow magically in the span of a couple of days changed into this major storm with tremendous impacts for our local community. This is also an experience that many others in other parts of the world experience as well. So these are not unique to us. And ultimately, when we start to think about that, and that's part of the reason that this is a challenging problem, is because it impacts almost every part of health. Some way or form, the data that already exists, climate change is impacting health almost every level. So even when you can have some conversations with people, and I remember one from a group of pastors, and their response to me was like, okay, this is all cool and interesting, but this is not what's on our radar. And I said, so what's on your radar? And they said, gun violence. I said, well, one degree of separation from that is that in more extreme heat, the ability to shoot other people goes up exponentially. So that's not something that's completely divorced there. And so this is where we need to start to make those connections because they're so critical to humans and what communities care about. So this has been a bit of an involved process to get here. The dean asked me March of 2024, which seems like a lifetime ago, and there are some photos online that might compare my age over that time, and it does induce accelerated aging. But we really tried to figure out strategically what were the priorities that we could come up with. And that was taking a lot of time going around campus, really reach out to all of you all and to ask sort of where you thought priorities should be. In addition, we did a survey, and you'll find that the survey actually guides what we're doing today and is really trying to follow that message. The first part of that survey asked the question of whether there was alignment of your research with climate change, or in a sort of separate way to ask kind of the same question. Most of the faculty said no. Again, I apply that 1 degree of separation rule. So I can poke a hole in whatever you do and explain how it has a climate impact. I challenge anybody to come up with an aspect I can't make like that. That's an opportunity here, and that's part of why we're here today. Try to help build the connections, information together, so we can start to think about how the work that we do can be brought to bear on this important health issue. And then on the flip side, everybody thought that it was really important, so kudos, and I think that's reflected in the enthusiasm we've had for this event. The other piece, and this directly informs today, obviously we thought that the faculty in general thought that networking and collaboration efforts were really critical. And so, hey, here we are today. And I would like to encourage you all to take the time, talk to people that you haven't met before, talk about sort of your aspect of what you think you're doing and why you're here, and to see where you have commonalities, because I think they all exist. Second part is always money, and so money does help us do all the things that we do. So that's certainly a big part of what we're going to be doing as a part of the initiative, is to try to help make these connections, particularly ones where they weren't thought of before, because those are some of the most exciting ideas, and figure out how to foster those and fund those to support their initial efforts to really solidify those connections. Couldn't have done this without a group of people that really were willing, of their own free time and effort, come together, and many of them are listed out here as part of an advisory panel that went through a lot of the information we collected, to really think creatively about how to inform this structure. And ultimately, what we came up with were 4 thematic areas, you can find these on the website, so I'm not going to go through them in too much detail. You'll notice that they span from basic science all the way to policy and working towards resilience and thinking about engineering strategies. Everything in between. Basic biology of how does heat affect the human body, how does it affect the immune system, how does it affect the things that we're exposed to, pathogens, both pathogenic and non-pathogenic. The data concerns, how do we take data that's increasingly evident in our environment, and we have tons of information, how do we apply that information? How do we make sure that the systems that we care about between health and climate actually talk to each other in a way that's meaningful? And then how do we actually organize it in a way individuals at all levels of care can actually use that information to help human health? How do we think about the global impacts of this, where the global needs are, and where there are commonalities between what we do here locally and what we do globally? How do we make those connections? And also, ultimately, what do we do with this information? Because it needs to ultimately improve health. So we were lucky, and I'm very grateful for the Duke Endowment for providing the funding that's supporting this initial project. The title of that is Combating Health Effects of Climate Change in the Carolinas. Their Duke Endowment is very Carolina focused. It doesn't mean that they're not interested in global activities. Thinking about all of these effects that occur in our local communities and how they're impacting our health. The other piece, and I think it's a good representation of what Mary Rice brought up in terms of relationship between tobacco smoke, and I do think that that's a really important thing for us to think about in the context of climate change. You don't want to wait 30 years research finally build to the point that we start to actually be doing something about health risks from climate change. Certainly we'll develop that information and that data to support that. I would really like to see this happen on a rapid scale. I think it was imperative, as something that Mary brought up, that we're also working on with Catherine leading this. How do we start from the beginning to think about where does the information, where does the science go? How does this lead to impactful things that happen in communities? How can we rapidly do that by thinking about it from the front end? So you'll see that as a critical piece. And this is actually something that the endowment challenged us with. Think about how do we start to come up with products and things that actually could be useful for individuals as a result of this research, which I think is really important. So you're going to hear from all these people. These are individuals who we identified early in our strategic planning process that had ideas that really were needed some funding, but were moving towards maturity, and also affected areas that we really wanted to focus with and fit within the strategic plan. So you're going to hear from all these individuals, so I won't belabor that. Now I want to come back to this. So this is why we're here today, really, this idea between seed funding and pilot grants and networking and collaboration. So we're really focused on that, and that's part of the reason for the Big Idea Symposium, right? So what I wanted to try to do, get away from maybe the standard way that we focus on these things, which is usually established teams that in RFA, they know that they can do that, they've already got the team together, they've already got the work together, and they start doing that. I really want to see new groups coming together, try to help facilitate and fund that activity to really do impactful work. It's also part of why, as me personally as a faculty member, but I think for all of you, the reason we're here is because we like that random collaboration that leads to something that's new we hadn't thought about before. So we're really trying to facilitate that. That's why those submissions for this idea that will then be presented as a subgroup this afternoon are really so critical to that. And kudos to the faculty and trainees. There were over 30 applications. There's a lot from a new idea. And for those of you that didn't get invited, I know we said this in our response to you all, but I will repeat it again. We really liked a lot of the ideas. It was really hard for us to figure out the number that we came up with. We were going to do this again. We'd like to see those ideas mature and to think about it, and we're actually going to help work with you going forward to that. So obviously there are some projects that are going to be presented as a part of the pitches. We're really excited for that. These pitches are designed to be collaborative, right? So after these individuals pitch, we're going to have them sit at different tables. The goal of this is to get you to come join the table and be a part of the conversation. Think about the own work that you do and how it might be brought to bear on the ideas that they're pitching. We want to make those ideas better, stronger, more impactful. We can do that together as a group. I also really want to encourage the graduate students, and I'm really proud of the people that put their name in the hat. It's hard as a graduate student to do that. So I'm really appreciative of the individuals that did that, and I'm going to talk about their projects as well. Ultimately, this is leading to some funding, so there will be an opportunity for these individuals to apply for full funding. There are 2-year awards, and we want to see that happen. And so we're going to try to help with that along the process as well. Finally, I would want to just point out that even beyond this work that I'm doing, there's actually a lot of stuff going on campus. A lot of individual groups that have been excited, engaged, and have done stuff, whether it's through the School of Nursing, OBGYN, Population Health Sciences, the Duke Global Health Institute that has a climate change and global health initiative that you all should look at if you're interested, and is doing some exciting work. And even some of the symposiums and seminars like the Health Reform and Climate Change. A lot of really exciting stuff going on. We are also, as a part of the initiative, here to help. Really want to try to encourage these kinds of nascent ideas to really develop. We want to try to help publicize them and help promote them. And so ultimately, even beyond the symposium and what we're doing here, we're really here to try to help facilitate that activity. We welcome your thoughts, questions, ideas, and comments. With that, pass along to the first of the speakers. That should be, I think.
All right. I'm Nrupen Bhavsar. I'm an epidemiologist in the Department of Surgery. I also lead the social informatics program within the CTSI, which tries to bring together data resources. We can advance some of the work focused on how where we live impacts our health. Today I'll be talking about the Seed Health Atlas data platform that we hope can help democratize the data that we curate. Just a little bit of background in terms of the development. As I started to do this work many years ago, one of the things I noticed is curating this information was challenging. You have to know where to get it, you have to know what geographic level to work with, and it was time consuming. And so as part of the CTSI at that point, we did a needs assessment with the Duke faculty and staff to understand how they were using this information and what could help them as they curate this information and use it. And so we went through the different schools and institutes within Duke. We also did focus groups with community members. Part of what we are interested in is not only using this for research. We want to share this with the community that is around us and empower them to use this information on their own. And so based upon the needs assessment within Duke, the focus groups with the community members, we defined a set of joint needs. I think everyone focused on having a central data resource that has an easy interface, the ability to link to other data sets, and the ability to communicate this information to the lay audience. As part of that, we did an initial prototype and then an iterative update to it. And this is currently where we are. There's a QR code if you want to go to it, and also the website. Initially, this started out very Durham-centric. We collaborated with the Durham Compass. We were providing them aggregated health data for their website. We wanted to expand outside of Duke, focus on the Duke catchment area. And what we realized in the development was it was actually not that much work to think bigger. And so what we did was we started curating data for the entire country. And so now we have data on about 150 variables across the entire country at 3 different geographies, the block group, the census tract, and the county level. We're thinking through additional geographies to add there. Data are available longitudinally, going back to 2014 when Duke instituted EPIC, and so that also affords us the ability to start linking this to health data. We also thought through additional health data that we could add to the website. While we have access to aggregated Duke health data, if we wanted to think about all of this more broadly, we needed additional information. So we brought in the CDC cases data and the 500 Cities Project, and they have information on the prevalence of various health conditions and healthcare utilizations for the entire country. And as I mentioned, we want people to use it. So we created a customized platform so that people can create their own CSV files to download, and then we also added an API layer to it so that people can bring it down programmatically. And importantly, if we want people in the community to use it, we have to make the information accessible. And so we translated the entire website into Spanish. As we move forward, we'll think through additional languages to translate it just so that there are no barriers to access. Everything that I'm showing you is publicly available, free to use. That brings us to the Duke Endowment Project and the goals of this. And so when Rob and I started talking about some of the challenges that investigators have at Duke, one of the main challenges is how do we get this information, and how can I make it usable? Often in its raw form, it really is not as useful as if you're able to curate it. Some of the things we will do as part of this is to bring in different types of climate data. So obviously heat exposure. And so we're working with folks across campus, including David Carlson, who's in engineering, to both look at raw temperatures, but then also think through things like wet bulb globe. And then he's also interested in novel measures, satellite-based estimates, bringing tree coverage, and the same thing with air pollution. Can we use novel sensors to be more accurate about that, data on floods? As I mentioned, all of this will be curated across the U.S. at multiple geographic levels. Importantly, we still want to have an engagement with the community. And so this is where I partner with Jess Sperling, who's in the CTSI and SSRI, to really understand how the community wants to receive this information, what is most helpful for them, what do they want to see on the website that can inform changes in the neighborhoods that they live in, that they want to see. And critically, the last part of this is how do we identify the individuals within our health system that are most vulnerable to climate change? And so partnering with folks in engineering and with strong backgrounds in AI, can we identify the people at risk so we can start targeting some interventions in terms of where they live? The other part to this is we also want to accelerate other projects. And so some of the natural fit that we see here is obviously the work you'll hear from Nishad and Mercedes, but then also from Keith in terms of the projects that they're working on, where we can help curate data for them, and so accelerate their work, but then also make it accessible for everyone else. And again, try to do this for the entire country so that you can collaborate with folks at other institutions, have a grounding in terms of the data that you're using. And lastly, the point that Rob made is a really important one. We want to serve as a resource for others in Duke. We don't want to duplicate effort. So if you are already working on certain things, let us know, and that's great, because then we don't have to put resources behind it. We can work with you. If you are interested in curating data that you might not have the resources to do, we're happy to help with that. If there's information you want to share with the community or with other investigators, please let us know. We do regular updates to the website, and we can serve as a resource for that. And if you need to link any of this information to the EEKH, also something that we have a strong background in. Key part is also integrating all of this in a timely manner so that you can make evidence-based decisions for both as researchers and as health system leaders. And critically, as we think about public health crisis and future epidemics and pandemics, we want to have timely information, and I think that's where we can really help with that. As I mentioned, increase efficiency and reduce duplication. The other thing I will mention here is I don't do this on my own. We have a team. I collaborate extensively across campus, and these are just some of the folks that are helping to update the website. And this is some of the groups that are both supporting our efforts and partners in what we do. So we'll stop there. I don't know if you want to take questions now or later. Okay.
Good morning. I'm Erin Hanlin. I'm an emergency medicine physician here at Duke. I'm also a subspecialty trained EMS and disaster medicine physician. And my co-PI in this project is Dr. Anna Tupetz, who's clinically a physical therapist, but is primarily a researcher with the Gemini, as well as the Duke Emergency Medicine Department. And I'm very happy to talk to you a little bit about our project that we've called NC for Climate Health, which at its core is focused at breaking down the barriers that have traditionally siloed academic research and community-level emergency preparedness by creating a academic community coalition for climate change and health that we hope will serve in the future as a point of collaboration and a resource for future academic, community-led, community-engaged climate research. Obviously, that's a really big lift, so we've kind of broken this project into phases using an implementation science framework. And I'll talk to you a little bit about today the first phase of the project, and Dr. Tupetz will talk a little bit about the next phases of the project, our scaling, sustainment, implementation. So why are we thinking this is important? I mean, I'm amongst a bunch of climate researchers, so we all know that, of course, our climate disasters are hitting with intensity and increased frequency. And of course, they disproportionately affect vulnerable communities, especially communities that at baseline are already affected by our social determinants of health. And we need to improve our community-level disaster preparedness and simultaneously improve our healthcare resilience. Traditionally, that has been done in very siloed ways. Each are doing their own thing. The government's doing their own thing to prepare. Community-level NGOs are doing their own thing to prepare. Healthcare systems, academics are doing their own thing. And then the academics are kind of doing their research over here, and it's all these different silos. And we want to bring these important communities together to start working on shared goals and bringing forth the community level needs that our research can focus on the things at the community level and what their needs are. And so in our first phase of this project, we are hoping to develop a strategy document on how to create this statewide community academic coalition. And again, we've termed that NC for Health. And a kind of a secondary objective, which will help to build that strategy document, is to create a disaster response resource map, specifically focused on different social determinants of health. And we'll be using Hurricane Helene as a case study to develop this resource map. We chose to use Hurricane Helene as a case study for a few reasons. One, it's still fresh in people's minds. And if anybody's been out to Western North Carolina recently, it's the ongoing damage is still, they're still dealing with that and still recovering. The other reason is because both Dr. Tupetz and I have experience with Hurricane Helene response, and I have a large professional network of people who responded to Hurricane Helene. We both had the opportunity to respond, and we actually worked at a shelter in Western North Carolina through the state medical assistance team, of which I'm the medical director. And so we have a network already that we can start using as a jumping off point for creating this resource map. So we're going to be focusing on these Western North Carolina counties that were most impacted by Hurricane Helene. Find using the NC Office of State Budget and Management, they define critical business disruption. And there's a very specific definition for that as a way of kind of a surrogate for areas that were most impacted by a disaster. So we'll be focusing on these counties to create a resource map, and so that we can identify the facilitators, identify the barriers to disaster response in this area of North Carolina. And this will just serve as an initial phase of the project. Dr. Tupetz is going to talk about how we're going to use this to go on to our next steps.
Good morning, everybody. So as Dr. Hanlin already mentioned, we're using Hurricane Helene almost as a proof of concept to say how do we identify community organizations in those 15 counties? How do we engage with them? How do we make sure that we learn not only what their responses were, but also, Rob pointed that out in our very first meeting, saying make sure to ask them what they need from us, right? So that we really think about that coalition, that collaboration piece. And then the next step after that, once we kind of identify how we can do that in an effective way to really start by collaborating, by understanding what the needs are, how we can help, thinking through what resources are at Duke. We've already been in touch with community affairs, for example, and really trying to understand also not, as you were saying, to not duplicate efforts, to really leverage what already exists so that we can create one resource map that says this is all the organizations that serve in specific areas of social determinants of health, and then understanding how they respond in disasters. So once we have that, we want to expand that one statewide so that all of North Carolina is covered, and then also expand it to South Carolina. As Rob was saying, the Duke endowment is for the Carolinas, so we want to expand to that too. And then we want to make sure that we also create those resource maps that currently is on the disaster response, expand that to disaster preparedness, for example, disaster recovery, so that we have different resource maps to understand who works actively to prevent, who works actively to respond. And then we want to implement that, and having that for Health Coalition, thinking through what implementation strategies do we need to have that coalition that is an ongoing conversation, ongoing discussion with the academic and community partners so that we keep understanding what is needed and where do we fit. And then sustaining that, of course, through that collaboration, through that coalition to have future projects that we can fuel. One example of the sustainability piece is we're currently working with graduate students in Dr. Stanton's implementation science course where as part of their kind of like end product is with us to collaborate on how could a sustainability plan look like for that coalition. So we asked them to really think through the frameworks that they are learning in class. So we're bringing in trainees from the very beginning. We're thinking through how can this look and have them involved from the very beginning. So just to end here, we want to make sure that we acknowledge David Marcy. He is the disaster preparedness director for the Duke University Health System. He's been very engaged with us in the Hurricane Helene efforts and leading that. So he is just a wealth of knowledge and has been able to connect us to a lot of state agencies already, and we're really grateful for him. And then, of course, the Climate and Health Research Initiative for providing us that funding, which is, funded by the Duke Endowment. All right, thank you very much.
Good morning, everyone. My name is Nishad Jayasundara. I'm an assistant professor in the Nicholas School of the Environment. I'm here representing a large group of people, but especially my colleague, Dr. Mercedes Bravo, whom we initially provided the thoughts around the funding that we received to think about this intersection between climate change and kidney health. I should mention that both of us have spent our careers really thinking about how does climate affect health outcomes and also the disparities associated with that. And through that work, we've identified kidney health as one of the major target diseases that we should be paying attention to. And I'm hoping that I could tell you a little bit about why that is and what we are doing in that space. But before doing that, I really just want to sincerely thank broader Duke efforts to continue the climate change. And that's incredibly important to see because over the years, we've built partnerships with communities to do this kind of work. And if this kind of funding had stopped right away because of shifts in the national policies, that would have really left the partnerships fractured. And I'm really grateful that we could continue this kind of work and continue to engage with the people that are most affected by climate change. So just to highlight the disease that we are thinking about, when we think about kidney disease, it's a growing global burden. About 15% of the global population is affected by kidney diseases, various forms. 1 in 7 Americans are at risk. It's a driver of cardio-kidney metabolic diseases. 43% of the U.S. Medicare budget is spent on providing kidney care. That's about $90 billion a year that's spent on dialysis and other forms of kidney care in the United States. But we still have a very minimal understanding of how does environment influence the health of individuals around us. And how we've gone about thinking about that is to focus on communities that are already showing increasing prevalence of kidney diseases around the world where they are directly affected by environmental change and they are also suffering from end-stage. So these communities, sentinel communities, they're telling us a lot about what are the environmental factors that are influencing health. And the hope of this new phase for us in this research, bring that knowledge to think about the same questions in our own backyard here in North Carolina. I'll show you a little bit about why we should care about environmental change when it comes to kidney health. I think we heard really nicely this morning. Climate change, together with environmental pollution, poses a significant risk to human health. We think kidney health as one of the major targets of that. We need to care about this because we know that Southeast United States, especially North Carolina, South Carolina regions, are one of the most vulnerable areas to climate change, but especially heat stress. And we are seeing that over and over in many different forms of maps that you might. We also know that climate stresses, including heat stress, amplifies effects of environmental pollution, both at the physiological level, but also at the environmental. Because of that sort of added burden on kidney health,
Time magazine went on to claim that chronic kidney disease is poised to become the black lung of climate change. Some might call that fake news, but I think it's closer to reality than we think. So why are kidneys susceptible to heat? A quick physiology lesson here. As somebody's heat stressed, there's reduced blood flow to your kidney because now your vasodilated, your blood is more concentrated or trying to evaporatively cool through, blood coming closer to your skin, and because of that, your kidneys are receiving less and less blood flow. Kidneys already operate at a low oxygen tension to maintain their reabsorption processes. So under heat stress conditions, kidneys go into hypoxic conditions. And there's hypoxia injury, there's reperfusion injury, there's direct heat-induced injury, and then there's dehydration-associated injury. And all of that sort of compile into increasing susceptibility to other stresses, including chemical pollutants. Kidneys, as a major filtering organ, already experience a large burden of chemicals in the environment, and heat stress will amplify the effect of those chemicals. We also see heat stress increasing or amplifying pre-existing kidney disease conditions. We also see there's a rise in acute kidney injury-related hospitalizations with heat waves. So we're beginning to see kidneys are becoming a target of heat stress, but also pollutant factors associated with that, which led us to form this Duke Environmental Exposure and Kidney Health Working Group about 5 years ago, and I'm representing some of the members who've been collaborators and pioneers of this work in really thinking about how do we measure the environment to better understand what are the factors that are affecting communities, and how do we better measure the biomarkers that might represent the threats coming. So we've developed a coalition of people that allows us to think about environmental exposures through these silicon wristbands led by work by Dr. Heather Stapleton in the Nicholas School. We can do this individual well water sampling, for example, in communities that are affected to figure out drinking water contaminant exposures. But I think what we are really hoping to push through this new phase of our research is to think deeply about heat exposure, which we've done in our communities that are affected, primarily in Sri Lanka, where we do a lot of work. And we use these wearable devices in our farmers as they work in the field to get a better sense of types of heat exposure that they might be dealing with during their occupation. So what this research has really highlighted to us over the last 10 years of doing this work in faraway places in the world that are experiencing large burden of kidney disease, that we really don't understand how stresses like heat directly affect an individual's physiological temperatures. That's such a fundamental knowledge gap in the field. And that's something I hope we could address through this work. And we don't also understand how that fundamental change in core temperature actually end up influencing kidney health. We know it applies to people. We don't know how. We also want to focus on susceptible populations, but especially children. We understand very little about how kids are affected by heat exposure as they go in to play soccer in the summer, or in these cases, communities that we work in Sri Lanka where they play cricket. We also want to think about mechanisms of heat injury through this work. And we're hoping to leverage 4 cohorts here, 3 in North Carolina and 1 continuing to build on our work in Sri Lanka, where we have a 3,500 pediatric cohort where we can continue to monitor their kidney health through some of these devices that we've built. We are working with Dr. Anna Strasma, who's done a lot of work last year to build a North Carolina agriculture working cohort. We're also working with Dr. Heather Stapleton and Kate Hoffman, who has built an amazing link with the North Carolina firefighters. So we have efforts to monitor their kidney health, especially pushes from heat and fires that they're fighting. And we are also working with the Duke Athletics to think about how our athletes are experiencing heat exposure-driven health outcomes. So moving on to the next steps, what I'm hoping is that this work will help us think about defining a new heat stress threshold for these outdoor susceptible populations. And kidney health and some of these markers that are being developed, especially by Dr. Hanlin and the Nicholas School, will help us better think about how can kidney health serve as a barometer of heat-vulnerable communities. Hopefully, we can also identify mechanisms of heat-related kidney injury and also try to inform who are the vulnerable groups, especially children and firefighters. Hopefully, we'll have better data for early warning systems, and I love what Nrupen had shared earlier, so hopefully we can work together on that. And eventually, the goal is to come up with scalable interventions, come up with better policies on heat exposure, and also think about potential use of wearable tech. And we, at the end, really hope that platform that we built will enable more collaborations with everyone who's here. So if you're thinking about cardiometabolic diseases and want to think about this in the context of these outdoor populations, please let us know. Would love to talk more about it. Heat exposure and microbiome research that I think you'll hear about this afternoon, heat exposure and mental health. And at the end, obviously, the goal is to be more community-based participatory research that we are already doing in Sri Lanka, but hope to translate some of that here to North Carolina and interface with more of those policy stakeholders and community stakeholders. With that, I'll just thank everybody here and also this amazing group of people that I get to work with. Thank you.
Good morning. My name is Erica Washington. I'm an assistant research professor in the Department of Molecular Genetics and Microbiology, and I'm here to present our project that I've been working on with my co-PI, Dr. Asiya Gusa, who will talk about her part of the work in a few slides. So I want to also start by thanking the Climate, Health, and Research Initiative for this opportunity and the leadership and support on this project as we move forward. So today I'm going to be telling you about our work to investigate fungal health risk in western North Carolina following the Hurricane Helene flooding. This is a large collaborative project that we've been working on with an interdisciplinary group from across Duke's campus. I want to start by acknowledging some of the people who have worked on this project. We have Andrew Jones, who's an assistant professor at the Pratt School of Engineering, who also works with Premier, the Precision Microbiome Engineering Group. Dr. Shingang He in Duke Biology, and 4 of the founding members of the Climate and Fungi group we now call CLIF, myself, Dr. Gusa, Dr. Joe Heitman, and Dr. Amy Gladfelter. Climate change is leading to an increase in the frequency and the severity of extreme weather events. And as we've talked about multiple times today already, this happened in our state and Hurricane Helene hit in September 2024. It brought with it strong winds, strong rainfall, and this led to flooding and mudslides and more than $50 billion in damage to the infrastructure in western North Carolina. And so, even more importantly, more than 100 lives were lost. This tragic event gave us the opportunity, however, to start to investigate how fungal growth and the health associations with fungal growth in this post-flooding environment. So 4 months after the Hurricane Helene hit, a group of us went out to Black Mountain, North Carolina, to collect fungal isolates. And we are fortunate enough to have a guide, Miss Angela Reeves, who works in the town as the project and facilities manager. And our goals were to determine the relative abundance, diversity of fungal species that were in the environmental samples from flooded facilities in Black Mountain, North Carolina. And then our second goal was to build a fungal biobank. This would allow us to culture, identify, and store unique fungal specimens that we identified, and this would be a resource for the research community. When we went to Black Mountain, we went to 3 different sites, and we collected both indoor and outdoor samples. First site was a golf maintenance site that had been closed since Hurricane Helene hit. And so this was a site that was filled with different fungal isolates that we could collect. And we also collected in the outdoor, and this was a non-remediated location. We also went to Veterans Park, which was a park that was completely destroyed from the flooding. It contained a playground, concession stands, and also a bathroom, also non-remediated. And the last place we went to was a public works facility that ended up being partially remediated. Importantly, these 3 different sites that we went to had differences in their elevation as well as their proximity to the Hurricane Helene flooding. They also allowed us to sample different materials, both indoor and outdoor. And overall, we were able to collect approximately 100 environmental samples. We then started processing.
So the next day was quite an adventure. We actually had to call on our troop of graduate students and trainees to help us on a Saturday morning the next day for plating out these isolates to ensure we had the best chance of getting what was representative at these sites. So we plated them out, and then we restreaked unique isolates to collect about 100 cultured fungi, as was described. We also prepared glycerol stocks so we could come back to those isolates. And so in the past 6 months or so, we've really been working on culturing and identifying these different fungi that we're growing, both in indoor locations and also outside. And we've been extracting their DNA and then performing PCR to sequence regions so we can identify these fungi. And this work is being done by Gabby Walker and Sam Schultz in my lab. And we were very fortunate to be able to partner with Jason Arnold, who's here, and the Duke Microbiome Core team. They were able to help us figure out a strategy so that we could actually get bulk sequence of our environmental isolates from each location. So this is relatively new technology where we can look at both fungi that are present in the samples as well as bacteria. We're able to get bulk sequencing readouts and then find the actual genre that are present in our sample. So what we've been able to do since then is look at all the different samples that we've collected and determine the relative fungal abundance and also the bacterial abundance. But I'm just showing you here the fungal abundance behind me. And I should mention that a lot of this effort was spearheaded by Julian Leiber, who's a graduate student, very talented graduate student in the Hay Lab. And he had experience sampling, environmental sampling before this, and also with this fungal abundance analysis afterward. So we've been able to identify in each sample what are the representative species that exist, or at least the genre. What's been great, as Erica mentioned, is that we have this Black Mountain fungal biobank that we're building. We currently have 44 cultured, banked, and sequenced to the species level, which you can't really get that information from the bulk sequencing alone. And what's been really fabulous is we have a goal of reaching about 300. This resource will be available to the Duke community and researchers beyond. What's been really exciting about this research is that we've been able to combine the power of bulk sequencing and also our culture isolates. So for example, what I'm showing you here on your left is a swab, like the plate that we initially cultured from the women's restroom sink in one of the bathrooms. You can see that the bulk sequencing was able to identify, Penicillium, Trichoderma, Aspergillus, Trichothecium, Cladosporium genre. But then, and we were able to culture some of those. But you can see that we're missing some of the cultured species, the Trichoderma and Trichothecium. So possibly what we plated out originally was not the best growth conditions. We can go back to that original sample and then play it out on growth conditions to grow those ones that we missed in our first initial plating. It's a really powerful tool to combine both of these approaches.
In alignment with the mission of the Climate Health Research Initiative, we wanted to highlight some of the fungal isolates that we identified that could have possible negative effects to human health. So we identified several emerging opportunistic pathogens, Aspergillus calidastis, Actiomyces varioti, and Penicillium chrysangenum. We also identified fungi that had produced harmful mycotoxins and have associations with allergy or asthma. So importantly, in the laboratory setting, we were able to culture these fungi at elevated temperatures from 35 to 37 degrees. This indicates that they're thermotolerant and able to grow in the human body temperature, which is indicative of them being a potential pathogen. So it's important to also note that these fungi can also have harmful human health effects even without being able to colonize your body. And this is because fungi can make harmful products in the form of volatile organic compounds, or VOCs, and also mycotoxins. One of the next deliverables of this project is to identify the mycotoxins and the VOCs that are being produced by the fungal isolates we found in the post-flooding environments in Black Mountain. Another deliverable that we're really excited to work on is to figure out if the fungal isolates we identified are susceptible to our current arsenal of antifungal drugs that we use in our clinics. And this will help us when we go back to the community to say, yes, we found this. Yes, we can also eradicate it or get rid of this fungal isolate with the current antifungal drugs that we have. We also, in my lab, one of the main focuses is to identify novel compounds. And so we have novel compounds that target a conserved fungal biosynthetic pathway that's required for thermotolerance. And so we're really excited to see if some of these fungal isolates are susceptible to our novel antifungal compounds. Also going forward, we have continued collaborative projects with Dr. Andrew Jones through Premier. We plan to simulate post-flooding environments in model facilities to test for fungal growth and toxin production under different conditions. And we also plan to evaluate different construction materials to see how these affect fungal growth during flooding conditions as well. And perhaps even to see how the construction materials affect the ability of the fungi to make these VOCs or mycotoxins.
Another really exciting aspect of this project that we didn't anticipate from the onset was that we had this rich source of diverse fungal isolates that come from the Black Mountain community. And there was a possibility to actually turn this tragedy into something really positive, into natural product discovery. But it turns out that fungi are natural producers of things like antibiotics and pesticides, that we've been able to harness that power over the years. But they still remain very understudied as far as their potential for different medical interventions and solutions. And so in collecting these fungi, we realized that we could possibly harvest the power of these fungi for climate and health solutions. Namely, my student Gabby Walker is now endeavoring on her PhD thesis project to look at the ability for fungi to produce plastic-degrading compounds. And that's a huge problem with microplastics in our environment beginning to really affect our human health. So I also just wanted to end by saying that we're sponsoring our second inaugural Climate and Fungi Symposium, May 29th. We've got a lot of amazing experts coming in to talk about these climate-sensitive microorganisms, these fungi. And so it should be a really exciting seminar that I invite all of you guys to the symposium. Finally, I do just want to thank also CHeRI initiative has been huge for us in opening up new avenues of investigation, which we did not anticipate, and also bringing together a collective group of folks that had never worked together, just as the initiative is designed to do. So thank you very much.
So good morning. I'm Keith Reeves, and it's my great privilege to speak on behalf of the Duke Immunology and Climate Exploration Group. First, I think I definitely want to say thank you to CHSI, in particular Georgia Tamaras, for supporting me in pursuing this new endeavor for us in immunology, and also thank, obviously, Rob and Catherine and CHeRI for giving me the opportunity to speak and work in this space, and in particular also acknowledge the Duke Endowment, which is providing support studies. So we are a truly interdisciplinary team. Myself, leading the DICE team, I'm in the Department of Surgery and Pathology and also Director and Center for Human Systems Immunology. Also co-led with Kate Hoffman, who's in the Nicholas School of the Environment. As you heard previously about some of our collaborators, also working with Nrupen Bhavsar and Julia Kroshenko in the Departments of Surgery, as well as Amy Cornelli, who's in Population Health Sciences, and Mercedes Bravo, who's in Global Health, as well as Clyburn Chan, who's in B. So obviously I think this illustrates just the importance, interdisciplinary nature of the type of work that we're doing. And I also just wanted to quickly acknowledge some of the folks in my group, Griffin Woolley, Karen Cherry, and Kyle Kroll, will actually be doing the assays and the analyses that are going to make all of this possible. So I think often I get this question, and people think about it, what could climate change possibly have to do with the immune system? And I think that was very nicely introduced for me this morning by Dr. Rice. But when you really start thinking about it, there are quite a few intersections between climate and climate change exposures and clinical manifestations from the immune system. So a few examples, thinking about air contaminants, which we've heard quite a bit about today, air pollution, as well as extended allergen and pollen seasons. These all can increase inflammation. They all impact overall immune function in the lungs. Also, when we think about water quality and access to nutritious food, we've heard a bit about that today. Obviously, that impacts your overall nutritional state, that impacts your metabolism, which can also impact function. Heat exposure, another one that we've heard quite a bit about today. Well, heat exposure can increase inflammation, We also know that increased heat exposure can suppress normal immune function, and increased heat exposure has also been associated with reduced vaccine efficacy. We also know that just generally speaking is that extreme weather events limit healthcare access, so obviously this is going to be an impact. And also I think it's no surprise that extreme weather events are going to increase potential exposure to new microbial pathogens. Something also I think that it's very important for us to talk about, and we've heard a little bit about this today, is that these effects are not going to be felt equally across populations. And indeed, the impact on vulnerable populations, which we've already heard a little bit about today, pregnant persons, children and infants, immunocompromised persons, and the elderly are going to probably feel the effects of this because their immune states are quite different from some of the rest of us. So going back to just sort of, the fundamentals of what DICE is doing, I think we all know that the immune system is shaped throughout our life by a wide range of internal and external factors. When you really start to think about it, and obviously what I was discussing on the previous slide, is that climate and your immediate environment, and by extension climate change, are going to be some of the most robust extrinsic factors. And so we're overall testing the hypothesis in our basic research approach that immune resilience or the dysregulation thereof could serve providing early warning biomarkers for climate-induced adverse health outcomes, and then hopefully provide us with targetable and implementable interventions for prevention or response. So we're working with a number of wonderful partners and cohorts. Obviously, we've already heard, there's a big focus in North Carolina. So we're working with the Personalized Environment and Gene Study, which is housed in NIHS. This is really a fantastic cohort, a longitudinal North Carolina-based cohort of over 20,000 persons that provides exposome, environmental exposure data, whole genome sequencing, as well as epigenetic and socioeconomic data. I think something that's really important that this cohort is sort of serving as a natural laboratory for us to test some of these initial hypotheses is that it really integrates the diverse microclimates that you see across the state of North Carolina. It also considers sort of the climate-related exposures that you may have in some of these different environments. It considers the different types of exposures that you may have in urban versus rural areas versus agricultural versus industrial areas, as well as incorporating social determinants. As has already been talked about earlier today, we're also working with Kate Hoffman in the North Carolina Firefighter Cancer Cohort Study to look at some of our immune signature measures, hopefully predicting resilience to exposure to hazardous chemicals and predicting subsequent development of cancers. Also going back to sort of those vulnerable populations, there's a wonderful cohort here, Project Hope 1000, over 500 pregnant persons and infants, where we're going to evaluate how immune health and predictive immune signatures may look at environmental responses in pregnant persons and see how this manifests differently from other members of the populations. And finally, my laboratories have obviously worked with persons living with HIV for most of my career, so we're going to be engaging a number of HIV research cohorts, as well as the Black Women and PrEP Task Force, to consider a number of the factors that specifically impact persons living with HIV. And I'll refer you to the graph at the bottom, because I think it's a very important point to make, that if you look at the globe and those areas of the world that are most at risk for climate change effects, and then you look at a similar map that shows predicted HIV mortality, those regions of the world almost exactly overlap. And so this brings, the immune system, as obviously I've talked about, it's a unique health challenge for persons living with HIV in particular, because we will potentially see expanded HIV opportunistic infectious disease, as well as additional healthcare access challenges. And then also there's considerations that these climate vulnerable populations may be more susceptible for HIV risk. So we'll be investigating both the intersection of climate and HIV health risk at systems level factors, and we'll also be investigating immune resilience specific for persons living with HIV, climate-related stressors. So what are we hoping to get out of this, sort of at the end of these studies and moving forward? So really, I think we're hoping to get biomarker screening tools, very sensitive immune signatures for climate-sensitive conditions that could be predictive of certain immune dysregulation and susceptibility to disease. I think we're wanting to apply more comprehensive immunologic assessments, particularly in these vulnerable populations, that will also feed back into some of these biomarker screenings. I think working with groups like Nrupen is we want to integrate some of this immunologic, social determinants data along with electronic health records and other data to make this as comprehensive as possible. And then leaning on our friends in bioinformatics and biostatistics to try and create computational models that will allow us to predict some of these phenomenon without assessing all of these populations. And then finally, I think we've heard a bit about we're hoping for community-focused implementations, and just a few of these that obviously we could talk a bit more about. But we're hoping that some of these studies will lead to more personalized health plans, potential rapid response toolkits that we could be providing to clinicians. And I think, again, as we've heard, thinking about North Carolina as the place to start, as sort of this natural laboratory, but also use it to build a scalable model that we could use for interventions going forward, both across the United States and globally. With that, I will stop. Thank you.
Hi, everyone. It's a pleasure to be here. I'm Elizabeth Rojo. I'm a PhD candidate at Population Health Sciences, and I'm here to talk about my dissertation project, Cultivating Unified Interventions for the Development of Safe Agricultural Responses to Heat. In short, cuidar. Cuidar is a Spanish word that translates to take care of. And I want to start by acknowledging the Cuidar team, my community partners, which have been very essential in shaping this study and this involvement with the community, especially after last year being very vulnerable for the community that I'm working with. And Piedmont Health, who is a federally qualified health center, and also community supporters, Access East, Amexcan, El Futuro es Nuestro, NC Fields, and Student Actions with Farm Workers. And Andrea Mendoza, who just joined our team. And I want to acknowledge my dissertation committee, Drs. Hayden Bosworth, Amy Cornelli, Leonor Cortino, and Kelly Taylor at UCSF. And to start, I'd like to tell you a bit more about the farm worker community. There are about 2.3 million farm workers across the United States. North Carolina is the 6th largest farm worker community in the nation. And some of the crops that North Carolina are first producer in the country are tobacco and sweet potatoes, and second largest of Christmas. We do have a lot migrant community coming to North Carolina to harvest those crops. This community has a lot of structural vulnerabilities. They are mostly Latino, Spanish-speaking, and Mexican-born. A lot of them, most of them, to work in the summer under H-2A visas, which are strict agricultural visas, as a way to import labor into the United States because there's not enough supply. They work at a piece pay rate, so that means that depending on how many buckets or how many boxes they harvest, that's how much earnings they take home. And so that's a big incentive to work extraneous hours and under hard working conditions. They have been a historically marginalized and targeted community. And so farm workers are 35 times more at risk of dying than all other outdoor workers. And this has a lot of contributing factors to it. There are economic, as I mentioned, piece rate, which incentivizes long hours, and occupational, meaning work intensity. It's a lot of intense labor, and they lack worker protection. So currently there's no federal standard that provides heat protections to farm workers, and only 5 states have some sort of protections. North Carolina is not one of them yet, hopefully soon. There's also environmental. So it's not standard that across all farms, farm workers receive water or shade or rest. And so these two, a lot of us sound like basic human rights, but they are not really provided across farms for farm workers. And there are structural factors as well. They have limited healthcare access, and then there's also the immigration concept for a lot of them. So some of the immediate impacts are heat-related illnesses, and we heard a little bit about heat-related illnesses and what they are: heat rash, dizziness, fainting, and the most severe heat stroke. There are also injuries due to fatigue. The more heat you have, the more impaired judgment, and mental health distress, and also increased pesticide exposure with the heat and the reaction of the chemicals in the pesticides. And some long-term impacts are cardiovascular disease, cancer, reproductive health, and acute kidney disease. And so there has been clear evidence that these three elements, water, rest, and shade, can prevent heat-related deaths, especially in this community. And so we know that. So as I was talking to community and farm workers and trying to develop the question, I wanted to learn more about interventions. And so we already know what would save lives: water, shade, and rest. So I wanted to know what interventions exist to address the extreme heat in the farm worker community, and what interventions do they want or they need. They look different across all farms: small-scale farms, medium, and large. So we developed this study, Cuidar, which is a mixed methods study. We are in the process of finalizing our survey, which we're going to launch in the heat season, which in North Carolina is from April to September. A lot of the migrant farm workers start arriving around March, so we're going to start deploying the survey then. We're also going to be doing in-depth interviews. We're going to form two cabs, one of farm workers and one of growers, to keep the power dynamics in check. And they were going to be our co-design team. They're going to help us co-design this intervention that we're hoping to have a toolkit as one of our outcomes. I'll talk more about that. And so Cuidar really tries to work with the community. We wanted to hear from the community and to see what interventions are out there. We're hoping to move beyond surveillance and education towards community-designed implementable heat protection. And so we've talked a lot about community, and in my process, for me personally, I wanted to be very intentional about community engagement and making sure that it is meaningful, it is ethical, and it's true. There's a lot of research that a lot of us probably have seen that says it's community engaged, but it's really not. It's very superficial. And so I came with the idea of wanted to do something around climate change. I wasn't sure what. I was raised in California, so wildfires were constant. I thought I wanted to do wildfires. But when I moved here to North Carolina, I never experienced a summer as hot as they are here. And so they got me to start thinking, what does the farm worker community do when it's just so hot? And so that's when I started engaging the farm worker community-based organizations. I reached out to the North Carolina Farm Worker Health Program, an Office of Rural Health, and they helped with the community entry and community outreach. So in talking with them, they liked the idea. They wanted to work with me and try to figure something out. So we reached out to CBOs, and they invited their collaborators. They said, there's a student from Duke that wants to do research. If you're interested, come hear her out. And so I spoke about a potential collaboration. Piedmont Health was there, and they said, we'd love to collaborate with you. And so everything was just going so great, and I was so excited. We were going to start doing the participant recruitment, but then there was a big shift in priorities at the national scale. And so there was a lot of uncertainty. This is my dissertation project, so I'm also working on a timeline. I do want to graduate. so I couldn't really play so much. But what I was able to do, and this is a part of my community as a Latina, a lot of things were also affecting my community. I decided to just keep listening and keep working with them. What were their priorities? Farm workers were experiencing different vulnerabilities in being targeted with immigration raids, and we could hear that concern, and how are we going to do this research in a way that we could also protect them? And so the community-based organizations, they had their own protocols. It was a big community effort. So I got to spend a lot of time with the systems as well, with Duke, trying to figure out how can we contract with our community partners. I wanted to really make sure we had some funding to pay our participants. And the money was disappearing. There were no grants. This study was just not a priority. So I thought about pivoting because I wanted to graduate. And my advisor and I, we said, okay, we're going to stay one more month. We're going to keep applying for pilot grants. And so then I got the news that the Duke Endowment had funded this. And so it really saved the project, and it really saved being able to ethically participate with the community and pay our partners for their expertise and their lived experiences. And so now tomorrow I'm going to start doing cognitive interviews, and hoping that in the summer, for when we actually have the survey finalized, we're going to have more student interns. We are hoping to get about 150 farm workers across the state. So if anyone has a student who's funded and might be interested in working with me, I'd love to talk to you. And so then hoping to get more data collection, and with the CAB, finalize the toolkit. And so one of our outcomes will be the intervention tool. It would be a ready-to-pilot intervention. We are hoping to have some targeted education curriculum co-developed for farm workers on health and safety, working on structural improvements, and standardized protocols for water accessibility, shade, and mandatory rest intervals, and then a cultural alignment too, community-vetted terminology for communicating climate and health risks. This community in particular has a lot of conflicting priorities, and so climate change to them is a long-term problem, when right now they need to make money and survive. So some of the three takeaways about Cuidar is extreme heat is a preventable occupational health threat. 2 is farm workers should be part of the co-designing process and not just recipients. And 3, Cuidar we're hoping that it will create a scalable model for climate resilient agriculture. And these are some pictures with and Cesar Chavez there and Dolores Huerta, 2 leaders in the farm worker rights movement.
Thanks to everybody. And so we have a bit of time to ask questions of any of the individuals that have spoken. Again, this is sort of a start-off point, so I hope that, as you have ideas or things that you sort of resonated with you in sort of the work that you do, that you approach all of them, because that's part of what we're trying to facilitate here, is that they certainly have these projects that they start, but they're actually looking to try to figure out how they can expand the work, and I think you can get a sense of that. With that, are there any questions that people have?
Wonderful work. I just wondering about a crossover between your projects. There's the heat-related kidney problems seen in Sri Lanka, Nishad's work, and I just wondered if that's also seen with farm workers in North Carolina.
That's actually a great question, and Nishad, maybe you can also add, but there's the study that they also mentioned with Dr. Anna Strassman, who's looking at farm workers in North Carolina, and now I'm also very happy to be working with her, but Nishad is the main mentor for that project.
What you said, and I think there's a lot of opportunity, especially there are different parts of the state that uses the outdoor environment in different ways in terms of the farm working activities. So thinking about what types of parameters actually pose a threat to health in different ways, including the immune system. I think there's a lot of ways to cross-collaborate and across different teams.
Thanks. Really great presentations, and really appreciate all the amazing work that you were doing. You know, a criticism of climate-related work has been we are attributing everything to climate change, not really teasing out what true climate impact is. And so how do you respond to a criticism that is basically, well, maybe, you know, kidney health was already here before climate change, or maybe we had a fungal problem before Hurricane Helene. And so I'm just kind of curious, or on the immune side, Keith, you know, what, maybe these are pre-existing issues. And so how do you respond to what is the marginal effect that climate change actually has on what you're seeing?
What I can offer just a little bit from the immune side, because we're obviously looking at, you know, health manifestations in the individual, but then also going down to sort of, you know, cellular levels or analyte levels. And I think for us, it's pretty easy to make that observation. Increased heat alters certain pathways of your immune system. This results in poor outcomes. So I think it's not as hard of a leap for us to say if you increase these individuals, particularly to nighttime heat, you are going to increase this. This is going to happen. And so if climate change is associated with this heat change, is what's going to happen. The same thing is, you know, these increases in particulate in the air, air pollution, air contaminants, increased pollen. We can see sort of in model systems or in individuals what this does to the immune system and inflammatory conditions that have disease consequences. And so I might leave it to others in the group to clarify that, yes, air pollutants are definitely due to climate change, but once we get down to our point, I think it's a very clear connection. And I think that's actually a strength of this area in quite a way, getting to sort of that basic biology to say, yes, there is a physiological consequence of this.
I would definitely second that. I think what you focus on is the real impact on people. Just like you said, there has been mold growth after flooding for decades. So it's a known fact. It's a real lived experience. We're experiencing greater flooding. We're experiencing historic flooding. We're experiencing flooding in areas that never had flooding before. So these real impacts on people. People are very concerned about mold growth in their homes afterward. They know it's difficult to get rid of. They know that there are health consequences associated with it. So this really gives us an opportunity to explore those more in depth and understand what actually is happening. What are the actual health impacts that are affecting real people in their lived experiences?
I would just add that, as you mentioned, social determinants of health, political determinants of health, we're going to see that a lot of the most vulnerable communities are the most impacted by climate change. And so we're going to see larger gaps in that. And trying to work through those first will also help climate.
Yeah, I'll just say, as an epidemiologist, we think about this a lot. And I think one way to think about this is the framework in which we look at this. And so making policy changes, let's say to lower thresholds for pollution, has a massive effect across the country or across the world. And then also thinking in terms of the interventions, in terms of something as simple as providing water or shade. We know what can help. The process to get there is incredibly challenging, but we know what can help. And so I think when we think about it, yes, it's true. There are lots of things that impact health. There are also a lot of things that we can do. We either have more information about it or make changes at sort of a large scale level.
I had a quick thought to say I would embrace the criticism and say, yeah, because the environment plays a significant role in our health. And that is why we are seeing climate being a major driver of health outcomes and actually use that to our advantage. So that is why we need to study this in depth. And I think really prioritize research that can have implementable solutions start off with to show that if we take action, we can solve that problem.
Thanks to all of you for your talks. Several of you brought up Hurricane Helene as a case study, and I think we can all understand why that's the case. And I guess adverse heat events, which are also increasing in frequency, are also serve as examples of to predict major events that provide a very public forum for alarm and for thinking and addressing climate change and its impacts. I guess thinking about Hurricane Helene, I think my understanding is that from the perspective of those counties that were affected in North Carolina, that was a 1,000-year event. Right? And so it's a useful case study. I guess what I'm wondering is, for the folks at the panel, but also just around the room, maybe for further discussion today, thinking about the observatory concept, can we imagine ways of collecting information at baseline from sites that will be affected by future difficult to predict adverse events? Sort of what would be involved in that? It seems like there's a possibility for connection panel now and around the room around that. So I would just more of a comment than a question, really. And well, maybe a question for you all is, within your current studies, are there examples where you're able to either retrospectively gather baseline data of areas that were affected, or have you already begun imagining ways of collecting data, stations and places that might be affected by similar events in the future?
I think that's a really great point and something I'm really excited about. Maybe we can think collectively on how to, I said, find baselines. For us, that definitely presented a unique challenge for our study. We tried to collect samples in some cases that were below the floodplain and above the floodplain, so we'd have some sort of basis for comparison. But I think we've shifted our focus, kind of think about, and then we've also collected environmental isolates from like the tree bark and from the surrounding soils, so we could see what's underrepresented in those or overrepresented in the homes comparison. But I think that we shifted the focus of our study to actually to focus on what are the fungi found in the environment and what are they producing. Was probably making the people. They complained about a lot of difficulty breathing, having cough symptoms, very strong respiratory problems, and they were getting massive headaches by being in the mold-infested environments. So we really kind of want to focus on what are these fungi producing? Can we simulate those environments since we have the fungi from those indoor environments? And grow them under different conditions, find out what they're producing. Dr. Erica Washington is going to be really important for looking at the mycotoxin production and what we actually think was making people feel ill.
To that, because I think there's a good perspective there, and certainly people should talk with Mercedes about the Global Health Institute's efforts, because that's really focused on some of these health observatories, and I do think that there's a lot of important implications for how we think about what's going on in different parts of the globe and whether they're common, whether they're distinct, and how that offers a case study in some of these events and what happens where they might be more frequent, and in many cases are. So.
Yeah, thanks, Rob. And thanks for this question. But since you did mention the observatories, right, the Global Health Institute now has this Climate and Global Health Initiative where we're establishing observatories, and those locations were chosen because Duke investigators already have deep partnerships, but also because they're climate vulnerable locations and populations. So, you know, obviously there's a lot of collaboration sort of among these groups already, but there are a couple different things that we're exploring, right? Really basic things like, can we collect X, Y, if you have study going on, hypertension, right, in Kenya, right? Can we get X, Y data on where people live or where people work, right? So that you need that data, you need to know where people are, right, to attach environmental exposures to them, right? And then sort of a little bit more work and a little bit more of a lift, but something that I think will be coming in the next year or so is we're also thinking about, are there a few sort of standard survey questions that we could ask people to consider adding to their, studies that they're starting or studies that are ongoing so that we can get more sort of information about people's, residents, movement, lifestyle behaviors, but that would be helpful to have kind of standardized across multiple studies and will facilitate more work that is related to kind of place, climate, and health of any number of different outcomes. Those are just a couple of examples, but yeah, I'd be really excited to talk to you and others about this.
Question.
Kate Webb, Psychiatry. I'll tack onto the Hurricane Helene question. One thing that I love about Duke is that there's a lot of well-established longitudinal studies. And so the Great Smoky Mountain study, half of the participants were affected by Hurricane Helene. We're working on a study right now that's looking at PTSD. They have 40 years of clinical assessments and biomarker data pre-Helene, and so we're collecting data post. So I think that is a major strength of having those kind of conversations too. Elizabeth, I have a question for you about how you're thinking about the immigration stressors currently and the psychosocial stressors that are affecting the community, and how you're thinking about interactions between, extreme heat and stressors to influence some of the health outcomes that you care about, and if you're incorporating that, and if that was feedback from the CAB of asking those questions. You mentioned that there was that pause and rethinking some of the outcomes in it.
Yes, thank you for that question. So we did consider a lot, not just climate and heat exposure, but there were a lot of other stressors and weathering that the community experiences. And so another part of funding, because I had to piece together funds for the study, another funder also does heat work with incarcerated population. And so because that was a very relevant topic in terms of detention and immigration, and so we added that element to our surveys and to our discussions and how could we meaningfully and ethically, without causing harm and mental health distress to the community, talk about those topics. So it's something that I am working with them and trying to figure out what's the best way, because we don't know. I don't know. I don't know their experience. And so that's why the partnerships have been so great.
All right. Well, with that, thank you to the panelists. And we'll move on. We have one more small thing before lunch, so please give a round of applause. All right, so close to lunch, and we'll have a couple of announcements just before we go to lunch, but I wanted to introduce Dr. Tighe Steelman. Dr. Steelman is the Vice President for the Office of Climate and Sustainability. And this is really, I think, undersold as the sort of brainchild behind getting the whole of university to start thinking about this, to really taking a bold step of trying to focus on climate and sustainability on campus that has trickled down through places like the School of Medicine and drove what you're seeing today. And so I wanted to give her a chance to highlight sort of how that works, and also to how we integrate here. It's all a group effort, and I think we're stronger together. So Tighe, would you come?
Thank you so much, Rob. And I just want to say how impressed I am with the whole event today, and extend a terrific thank you to Rob and to Sally and to Catherine and the incredible work that you are doing to lift this up. I think it's a terrific example of how we are trying to make this a whole of university effort. And to see the School of Medicine as a lead and a catalyst for the rest of the campus to lean in this way is incredibly inspiring. I think when you think about the opportunities of what you can do as an entire university, and of course that extends to our colleagues at Duke NUS and to our friends at DKU as well, it's a really powerful statement. And I think it's even more powerful at this moment, given some of the challenges we face in the climate, environment, sustainability world, given the national tenor towards the things that we care about. So it's a real, I think, boost being here today to see what you're doing. I take a lot of inspiration from that, keeps me going in terms of some of the challenges that we all face on a day-to-day basis. So, you know, just a big thank you to what you are all doing to lift this up, because it really does take a village. And you see so many people doing so many amazing things. So thank you for the time just to talk a little bit about our climate commitment. Our climate commitment is a whole of university effort, as I've indicated, and it is, we have a terrific annual report that we group source from across the university, and you see action in literally every corner of the university, people coming up with ideas and moving things forward. We have 5 pillars, 5 areas where we are trying to have an impact in terms of how it presents itself, everything from sustainable operations, how do we make our campus and our health system as sustainable as it possibly can be, to our educational integration, how do we create climate fluency appropriately across the campus, external engagement, how do we make sure we are reaching out beyond our own borders to create partnerships and have influence in places that really matter so we can have impact. Research innovation, which is a terrific example of what we're talking about here today. And then, of course, community partnerships, everything from the local to the global, because unless we are actually creating those meaningful partnerships, it's hard for us to really have impact if we're only doing it on our own. Our research themes, we have 3 major research themes. One is on oceans, one is on finance and policy, climate finance and policy, and the third really on health. And so one of the reasons we want to raise health up is because of the enormous presence that we have on campus, our School of Medicine, our School of Nursing, our health system, Duke NUS, a huge asset in terms of what we have. And when we think about the imprint of climate on top of that, it really, you know, is an incredible distinguishing feature of what Duke University can do in this space. So very exciting, again, to see, Rob, your leadership here, how you have raised it all up in a very, very short period of time. And I think it's a terrific example of how universities can actually move quickly when we want to. We're not really known for that, but I think when we turn our attention wholesale to do these things, we know how it's done. And I think what really impresses me about climate and the work that's going on in climate and health, and Rob alluded to these as we started today, climate is a force multiplier on all the things that we already care about. You know, the existing vulnerabilities we have in society. We know that those vulnerabilities are going to be exacerbated by the impact of heat and climate and the other things that come along with it, the extreme events that are associated with it. You know, one of the things that is incredibly inspiring by the health professions and what people who care about health do is that you care about suffering. And putting people and suffering and the way we can avoid unneeded suffering at the center of the work that we are doing, I think is a lesson the rest of us in the other areas where we are working can really take a page from what you are doing. And I think Rob has really coached me on this. He feels like, in part, we're starting to lose the narrative on why climate is important. And when we put people back at the center of it, it is absolutely undeniable. And Elizabeth, I think your work is such a great example of that. You know, how do we put people at the center of the work that we do? And so I think the more that we can do to raise that up and emphasize, you know, how it matters, why it matters. And, you know, we've got this terrific campaign on how Duke research saves lives that's going on right now. And it's just such a beautiful expression of what that really means. So I love the messages that are coming through today about how you're putting people first, how we can make that a more resonant message in everything that we do, because it matters so much. So I want to I want to make sure I emphasize a few things that are going on in our office before I step down and let us get to lunch. And these have to do with our vision of what we want to do in terms of educational integration. And our goal is to put climate-relevant content throughout all of the curricula that we have, appropriately so. It doesn't need to be center stage. But the work that Val is doing in nursing, we know there's more work going on in the School of Medicine and work going on elsewhere, because we know our students are absolutely going to need this kind of complementary, supplementary training to be effective in what they want to do. We have a few programs on campus where we can help in some areas on this, and I just want to make sure people know about them. We have Sustainability and Climate Applied Learning. That is a program basically where we use Duke as a living lab, and our staff basically help connect you to living learning projects on campus if there's something that's going on. We have a Climate Plus program. I know the fungal research has taken advantage of this in the past, but we have a deep dive in data basically effort. So if you have a smaller project that you want to get launched and at least try to create an initial data set, this is a really good program for that. Reach out to our office. Happy to connect you with that. In terms of research innovation, we recently launched a new, what we calling a Scales postdoc program. Nishad and Mercedes have been successful in landing one of these initially out of the gate, so congratulations to them on that. We'll have a larger announcement around this that's coming. But we will have another competition for this coming up probably in the next few weeks. So we had 20 incredible proposals that came forward initially in this competition. Really, really terrific ideas. Not all of them were successful. We're providing feedback. We want you to take those proposals, rework them, and re-engage in the competition going forward. We want to try to do three things with this program. One, provide support to our faculty, our staff who are already here doing terrific work, and let you know that Duke continues to support climate research. Second thing we want to do is send a really strong signal out to these early stage professionals who are just graduating to know that they have options, even if the external environment is not quite so great for them right now. Duke is a place where you can come and have a postdoc. And three, we want to make sure people know that Duke is hanging out our shingle to say this is a place where you can come and do climate-related research. Really important that we let people know that that is something that continues, and we're going to continue to fund it even if the external funding environment is going to be a little bit rough. So I just want to end by saying thank you. We have a terrific 2030 strategy out there in terms of where we're going and what we're trying to do. The work you're doing here fits beautifully into that. And check out if you want a little bit of inspiration to find out what's going on all across campus, check out our annual report. All of this is on our website. And I just want to say thank you because it does indeed take all of us. Thank you.
One of the key features and part of the reason that Catherine's going to be talking is to think about how do we take these interventions and think about the impacts and outcomes. So this is her area of work. She's an amazing scientist in her own right, and I will leave it up to her.
Thank you, and good afternoon. As Rob introduced, I'm Catherine Stanton. I'm an emergency medicine physician and implementation scientist. Part of the reason I say both is because I have a very short attention span, so hopefully that conveys. Part of the reason I became an implementation scientist is because I got so frustrated with my work. There were so many things we could prevent and that we know but isn't in place. You talk to an implementation scientist, 90% of the time the first words out of their mouth are going to be, it takes 17 years to get what we know into practice. If you haven't heard that before, I'll say it again for you, but just talk to another implementation scientist. They'll say the same exact thing. I am a global health implementation scientist, so guess what? In my world, I never get into practice. So that's very frustrating, especially when we're sitting on the clinical side saying, I know I could fix this, but I can't fix this because we just can't do it. So how do we fix this? When we think about climate change and this very complex situation, not only have to think about from the very beginning, what are we going to implement, but how do we put this in place to be able to make it work for our patients, our communities, and our environment? So as we started to bring together the proposal for the Duke Endowment, we had these amazing scientists who are all sitting in front of me who has the excellent ideas and create these incredibly imaginative projects, advanced innovative science. And then our funder said, how does it touch the community? And we looked at each other like, which community, right? Because many of our communities, like our scientific communities, learn from everything we talk about every day, because right here we're all learning from not only ourselves but each other. But there are so many different communities that we need to understand who are the communities at the table and then start the conversation early on how to do this. In climate change and health initiatives, we have a lot of things that are flowing into our environment to be able to start to think about. In terms of data and data people, we have people who innovate, we have people who talk with our vulnerable populations, our communities in general. And we're starting to identify different problems that you've heard before today or now. But as we start to think about what tomorrow is going to look like, the first things we have to do are start to think about how are we going to contact or impact our communities. What are our communities? What do they need most? Some of the first steps you've heard are asking our community, what do you need? What are you most worried about? How do we do this? And while that has to happen in the very beginning of a project, many of the things that happen after that also have to be community driven for us to be able to have a quality implementation. So how are we going to think about this thing that is climate change and health toolkits? Overall, every project that not only you've heard before, but that you will hear after me, has many different layers of communities. We have individuals that at some point, it might be a practitioner like me in the emergency department, or it might be interpersonal components or family structures, institutional communities, or policy or cultural levels. And each of the aspects, these levels of toolkits, need to be available and constructed with these people in mind. So our health professionals need to have verbiage, what and how we should talk to our patients, and at what time period. Our teachers need to know who and how to talk to their students, and at what time periods. Our institutions need to think about the same thing. And so developing from our amazing scientists some of these toolkits at each of the levels is going to be incredibly impactful. So the scientists that have spoken to you today, they're creating the discovery, whether that's in the bench or it's in the translational sciences or it's with the communities themselves in making this innovation and how to implement. We're going to work together. That's the best part of my job, is I get to work with every single one of you, be able to say, so who, why, and how, and what, and I keep asking questions. And what I get to see is that the scientists that are running their project, they start to understand, oh, those are my communities, those are all of my communities. And then they can start to say, oh yeah, I see all of these different outlets. I see all of the different ways that I'm impacting my community. Because I have a very short attention span, I need early wins. Guess what? That helps your science too, and it helps your funding. So part of the toolkit development is for us to identify early wins along the process so that we're not like 15, 17 years from now we've implemented something. We have something over the next months that we can then give to the community. Might not be the end of our science, but it is the first step in making that link to the community, demonstrating impact and process, and can rope in the community for more participation moving forward. So how we develop these resources and toolkits is going to depend on the project. Every project is and should be different. Every project should have something a little bit different based upon what their needs are. Their communities might be more hospital-based, or it might be hospital leadership, or it might be the community that it serves. And we get to think through each of those aspects for each project and determine what that looks like. And then finally, at the end or as we're doing this, we get to do knowledge transfer. How are we doing that? Teaching? Are we disseminating information? Are we going to policymakers to enact policy? What I don't have here is I will also help with evaluation. So as we're doing each of these toolkits and we're hopefully implementing them, we want to create an evaluation plan with you that you can start to see not only
what we'll put in place, but how we'll make sure it's the right thing, creating the strategies to get it in place and get it used, as well as to create the evaluation plan to make sure it's how we want it and we can. So, brief 10 minutes about how my entire workload will be, but it's an honor to really get to work with amazing scientists creating this really cool discovery and innovation, and we hope to be creating resources for you to think through your science and apply to your science as to what your toolkits will look like and how we can create them together for improving science and for our community. So next up, we have our first pitch from our big ideas.
We love technology, so we're doing a challenging technology integration with this pitch. And just in case, we have a video backup as well. So our big idea is to bring digital twin AI technology to Duke as a research laboratory for hospital-affected disasters. I'd like to thank the big ideas and the climate commitment leadership, Toddy Steelman, Bob Tighe, Catherine Stanton, and Sally Taylor for your brilliant energy and effort for making this possible. I'm Jessica Kastner. I'm climate leader in residence at Duke University's Nicholas Institute and the Duke University School of Nursing. I'm joined today by Judy Ledley, Pratt Engineering and Nicholas Schools, Director of the Design Climate Program, and Anthony DeMatos, a Chief Technology Officer with our industry partner, Cyclops. Next slide. Climate change amplifies the death and destruction for natural disaster risks with nearly 20,000 disaster deaths and $2.9 trillion in economic losses to the U.S. economy over the last quarter century. Coastal states like North Carolina face an exponentially increased unmet need for disaster management for flooding and sea level rise. Even today, if as small as a Cat 2 hurricane had a direct hit on a hospital, 50% of our Gulf and Atlantic Coast hospitals are at risk for serious flooding. For rigorous research, obviously we can't ethically do controlled testing to reproduce this kind of disaster condition. Simulation and drill environments are essential. The requirements today for hospital tabletop drills have a lot of limitations in scope and reach. Here, we substantially advance the field of hospital disaster research, education, and simulation training. We're meeting the need for enterprise-scale operations with the potential to engage every employee, ethically study workforce well-being in disaster crises, and generate novel clinical simulation training environments. Next slide.
Our solution is a digital disaster research laboratory. We propose using digital twins to help hospitals better prepare for disasters. By using digital twins, hospitals can model their procedures and more accurately predict what's going to happen. And they can do this while not having disruptions to their staff or their day-to-day operations. We're lucky to have with us our key partner, SETI Inc., who's developed a PsyOps digital twin platform. Digital twins are virtual replicas of real-world assets. They allow us to model place, procedures, and systems. What's also unique about the platform that we'll be using is that it incorporates low-cost, large language models to enable easy-to-use search functionality. Here, why don't we show you what it looks like?
This is where we had a lot of fun in preparing. So in 30 seconds, we're going to try to do this. We first create the hospital digital twin modeling and building in 3D. Then connect real-time data sources like building sensor systems. The key is knowing that what you have and to what extent clinical and patient modeling can be added. Here you see facility infrastructure and room layouts all visualized. The AI model enables searches for disaster plan information, best practices, and other manualized recommendations for real-time decision support. From this facilities engineering model, we will innovate novel layers to the twin for insights in clinical decisions during flooding and evacuation. For example, a data layer of de-identified dynamic patient room assignment with flow, acuity, principal diagnoses, and key risk factors will inform patient triage, clinical workflow, and evacuation drill scenarios. Our strategy and milestone for the first stages of Duke Digital Twins is to prototype the Duke University Health Emergency Department flooding in 2024. This is a success use case of management that could be used by other sites for training. Prototype 2 is a simulation training prototype of a full hospital evacuation. Finally, our usability and feasibility testing of the digital twin use case will enable us to study decision-making impact on simulated patient safety endpoints, health worker and clinician occupational stress responses, equivalent to a phase 1 STTR or SBIR. We will explore joint venture creation opportunities for scalable, commercializable applications. Duke Design Climate will lead a student-driven business model development. Next slide.
We've been incredibly intentional with our team building, incorporating academia and industry partners, incorporating specialists from the health system as well as engineering. For more information on our team, please check out the QR code.
All right, and with that, we welcome your collaborations. Thank you.
Thank you, Dr. Kastner. Our next speaker will be Dr. Christopher Newgard. He's going to talk about climate's hidden cost, how early life stress affects later in life cardiometabolic disease risk.
Thanks very much for the opportunity to be here today. I'm representing a team with complementary expertise, Rana Gupta and Diego Bojorquez, both younger and better looking than me. So we're going to try to fill a need here, or at least address a need. Triple threat of poverty, food insecurity, and climate change all contribute to the development of cardiometabolic diseases. And specifically, what we want to do, find interactions of early life food insecurity and temperature exposure in programming of latent cardiometabolic disease phenotypes. And we want to use preclinical models where we can be highly mechanistic, and also to test a novel interventional strategy targets gut neuronal cells that's come about from the research of Dr. Bojorquez. Now, we really have the goods to be able to do this. And it turns out that my lab, over the past couple of years, has been working on a model of food insecurity, while side by side, Rana Gupta's lab has been working on models of acute temperature exposure. Quickly, the food insecurity model, we use young male star rats. We let them feed ad lib or with a food insecurity intervention. And here, food insecurity means lesser amount of food provided sporadically. Do that for 20 days, and both groups of animals are allowed to feed ad lib on the high-fat, high-sucrose diet for an additional 8 weeks. And remarkably, that short acute food insecurity exposure leads to major changes in tissue outcomes. So, for example, in the liver, you see a reduction in fatty acid oxidation indicated by reduction in fatty acid-derived acyl-carnitine metabolites measured in our metabolomics lab. This is accompanied by changes lowering of levels of enzymes of fatty acid oxidation. And we think what happens is that the fat that's not being oxidized in the liver is ported over to the adipose tissue, which expands. The fat depots are larger in the animals exposed to food insecurity. Their fat cells are larger, and their fat cells are more inflamed. So acute exposure to food insecurity engenders all of these indices of unhealthy liver and adipose remodeling. Similarly, Rana Gupta's lab has looked at both cold and heat challenges in an acute sense. We start with cold at the bottom. So 2 weeks exposure to 6 degrees centigrade versus normal 22 degrees centigrade. Let the animals recover at room temperature for a period, and then feed them a high-fat diet. And remarkably, the animals that got the brief exposure to cold have a much better outcome in terms of glucose homeostasis when fed the high-fat diet, and very healthy-looking fat tissue. Conversely, if you do an acute exposure to high temperatures, 32 degrees, recover and then do the high-fat feeding diet, these animals have a worse outcome in terms of the normal temperature-exposed animals and very unhealthy-looking fat. So we have these two models in our Duke Molecular Physiology Institute, but we've never looked at the crosstalk, potential integration of the impact of these two interventions, and that's what we're planning to do in our proposal. And what we're also going to add is a potential intervention that comes from the research of Dr. Bojorquez. So Dr. Bojorquez has been studying protein restriction, lesser protein in the diet, and what does that do? And it turns out that what it does is it makes the animals nervous, and it changes their eating behaviors. They now seek carbohydrate-containing diets more aggressively than other kinds of diets. And this, Dr. Bojorquez believes this is driven by neuronal cells in the gut that he calls neuropods, which communicate with other components of the nervous system, the nodos, ganglia, the brain, etc. And he has found that the responses to protein restriction can largely be rescued by the provision of lysine supplementation. So here what we're going to explore is if we do the combined food insecurity and heat stress intervention, do we activate these signaling pathways? And is it possible that lysine supplementation can be an early candidate as an interventional strategy for the combined stress, food insecurity, and heat exposure? So what we're actually going to do, first of all, Ron and I are going to test the combined stress of food insecurity and high temperature, very simply. So we're going to feed the high-fat, high-sucrose diet at 32 degrees or 22 degrees. Then we're going to let them eat ad lib for 8 weeks and do a whole bunch of molecular and behavioral kinds of profiling. And all of this is available, by the way, at the Duke Molecular Physiology Institute. So this is a way that we can give back to this community by being able to do all of this kind of molecular profiling. And then a second arm of our work that we propose, do the food insecurity at high temperature and give the high-fat, high-sucrose diet during the food insecurity intervention, but also give a high-fat, high-sucrose diet that has been supplemented with lysine, see if that's a successful intervention. My last slide, Bob was very encouraging, perhaps insistent on. Make sure as a basic science team that you talk about what are the connections, what are the potential translational connections. One is Diego is leading a BioSculpt initiative here where we're actually doing a protein restriction intervention in humans and then using specific amino acids, including lysine, to determine the role of gut sensory function on food choices during protein restriction. That's in humans, so that connects to everything I talked about in our preclinical models. Sarah Armstrong, who's also here in the room, the director of the Duke Center for Childhood Obesity Research. She studies food insecurity and obesity from infancy here in the Durham community. So this allows us to ask questions relating to the preclinical work. Does seasonality and temperature affect food purchasing? Does this vary by housing stability and air conditioning? And among heat-exposed infants, does a dietary intervention removes food insecurity in these households versus usual care? The WIC benefit is usual care. Does this change health behaviors or health outcomes? So connections to exploring translation of our basic findings to an actual community project. And last but not least, Dr. John Rawls, who will be speaking here shortly, we've collaborated with John over many years along with Dr. Armstrong. And in a preliminary collaborative study in our food intervention model, food insecurity model, we have found that food insecurity fairly dramatically alters a microbiome speciation or composition. I think that holds out a lot of hope for connecting to microbiome research through these activities as well. Thanks very much for your attention.
Great. Thank you, Dr. Newgard. So our next speaker is Dr. Sudha Raman. She is going to talk about heat paths, identifying causal mechanisms of heat on mental health, pathways to intervention.
Tomorrow's forecast is not just a heat advisory, signal for mental health risk. For people living with depression or bipolar disorder or schizophrenia, and for those who we already worry about in heat, older adults and older parents, child or teen or someone sleeping outside, extreme heat can quickly push mood, behavior, stress, access to health care, and medication safety to the wrong direction. But in the field right now, we have a dangerous disconnect. We have researchers like me uncovering mechanisms without a direct path to action. At the same time, in the presence of these increasing risks, each year, clinicians are making interventions and trying them out, but not actually knowing what levers work and how best to implement them. So I'm Sudha Raman. I'm in Population Health Sciences, and the Project Heat Path bridges that disconnect, bringing science to real-world care and fast enough to matter for the next heat wave, but robust enough to make a difference and help us lead others in the nation to follow us. The goal of our project is to build a learning mental health system. It kind of picks up on these ideas of implementation science and getting things to people right now in the face of climate risks. The goal is to build a system for heat risk. What it is an adaptive framework that uses data, insights, community input, and clinical practice working together to continually inform each other. All right. On your right are the components of a learning health system. This is a known operational health system concept where we have not just these components, but this this cycle of learning. Clinicians, patients, and researchers work as a team, identifying problems, testing solutions and implementation strategies, measuring impact, and then rapidly iterating. For mental health and heat risk, what that means is that we are going to study how heat affects mental health for at-risk patients in particular, and then we build the structures and processes to respond to those risks so that our interventions are developed alongside the evidence. On your left, you see what we propose. First, we bring together stakeholders to identify priorities and directions that they're interested in terms of psychiatric medications, access to health care, potential social factors, building on what we need to know about climate change and heat in particular, and mental health outcomes. Compare those insights with quantitative analyses, linking climate and health data to pinpoint who's at most risk and why. And then those findings feed directly into co-designed processes or a series of processes where clinicians and community partners help shape these practical interventions, whether they be heat risk identification tools or care pathways triggers or decision support strategies on the individual level or potentially on a system level. Finally, we test feasibility, acceptability, and scalability so that we have potentially interventions into up to 3 at-risk groups: older adults, children, and people who are unsheltered, creating this continuous cycle of learning. There's going to be a lot of decision points along the way, so we assume that our deliverables will kind of mirror what we were talking about earlier in terms of toolkits, protocols, potentially data resources and analytic pipelines, collaborative networks, and example case studies so that other health systems can take this example and adopt or potentially adapt for their environment. We are building on 3 different building blocks here. One, we have an ongoing Vast Connections project, which is thinking about how to synthesize the evidence of what we know now about interventions and effects for people with existing mental health conditions. As well, we're looking at building a sampling frame for engaging with communities so that it's done in a more conscientious way. Next, we're we've already linked data within the population health data share, linking Medicare data with heat data to try to figure out how we can move from data to evidence to action without having to wait for that infrastructure to be built. And I've heard today about a lot of data infrastructure that's available here at Duke that we particularly could leverage. And the last part is that we've made some connections with a growing group of committed partners, including community groups such as Carolina Advocates for Climate, Health, and Equity, a group of clinicians, as well as clinicians in the School of Medicine, including psychiatry, School of Nursing, Nicholas School, and Global Health, who bring expertise with epidemiology, implementation science, like my co-PI, Ms. Gray in Global Health, And we're looking for other collaborators. So I hope that I've piqued your interest and look forward to the roundtable discussions, and we can make this big idea and take it to the next level.
Thank you, Dr. Raman. So our next speaker is Dr. John Rawls. He is going to talk about uncovering the impact of heat on the human microbiome.
Okay, good afternoon. So I know I've learned a lot today already, and I imagine you all have, about some ways that heat exposure can impact upon human biology. And it seems that we already know at least a few of the direct impacts of heat on human health, including direct and indirect impacts on our physiology, infectious disease risk, socioeconomic outcomes, and food and water insecurity. The focus of our project is an aspect of human biology that has perhaps received relatively less attention in past years, and that's the human microbiome. So as we're all probably aware, the human microbiome consists of many hundreds of different species of bacteria, fungi, and archaea. The composition of those communities differs wildly across the landscape of our human bodies, both exterior and interior surfaces. And alterations in the composition and function of those communities have already been linked to a variety of different human diseases and aspects of our normal human physiology. What we might not always think about, though, is that any heat exposure that we experience, microbiome experiences it also, both inside our bodies and outside our bodies. Periods of intense exertion in the human body can raise core body temperatures of 2 or 3 degrees. And so again, those either both environmental heat exposure and exertion-associated heat exposure can impact microbes as well. And then importantly, our generation time is a few decades. Bacteria, the generation time is hours. So the potential for even short-term heat exposure to impact evolution of bacterial lineages on our human body is greatly accelerated. For all those reasons, we think it's worthwhile trying to understand how heat exposures can impact human microbiomes and the symbioses, symbiotic relationships that we develop with them. So we have 3 objectives. Oh, sorry, I should have mentioned, this project is conceived initially conversations between myself, Nishad, Jayasundara, who we heard from earlier today, Julia O, in dermatology, who was not able to attend. We have several objectives. First is, in isolation, can we understand the plasticity of the human microbiome in response to heat? So our hypothesis is that within the hundreds of microbial species that constitute the human microbiome, we're going to see different capacities to adapt to heat among those lineages. So we already have libraries of bacterial and fungal isolates from human skin and human gut. We can very easily in vitro grow them under different heat conditions and then measure relatively simple outcomes like growth curves, gene expression, and the kinds of pathways that are affected. And the deliverable here, in a relatively short time frame, is foundational knowledge about how heat affects those microbial lineages in isolation, which allows us to predict how other types of real-world heat exposures may affect the activity of these communities. The second set of objectives has to do with looking at host microbiome symbiosis. So can we look at existing rapidly deployable models of host microbe interaction to ask how heat can affect those relationships? So our first hypothesis is focused on human skin, and we're going to hypothesize that those relationships will be affected by heat exposure. We're going to take the same collection of human skin microbes that are already in isolation and use existing human skin organoid cultures developed in Dr. O's lab and expose those to different microbial consortia and products, and then rear them under different conditions, and look at simple measures of organoid physiology and also host and microbial gene expression, and ask how the symbiotic relationship is affected by different heat. The next objective is taking it into a living vertebrate and ask how the host microbiome symbiosis is heat in that. Here, we're going to take the the unusual step of focusing on an existing model system that Duke has established on campus, which is the zebrafish model. You can ask me during the Q&A why we think that might be useful. This is a cold-blooded vertebrate, so it does not have endothermic physiology, so we can ask questions about how heat affects host microbiome symbiosis without worrying about the caveats of endothermic physiology. And we can take an existing collection of microbes from wild zebrafish, colonize germ-free zebrafish in a very cost-efficient manner, rear them under different conditions, and measure the symbiotic relationships through host tissue physiology and gene expression and microbial biology as well. And again, this is going to give us an organismal level view of how heat affects host microbe symbiosis. Finally, we're going to translate some of these questions into human populations. And we've already heard from Dr. Jayasundara today about some of the ongoing cohorts that are developed in this group. We're going to leverage those and ask if occupational heat exposure affects composition of human microbiomes in the real world. So we're going to choose between some of the existing cohorts of farm workers, firefighters, or Duke athletes, and monitor their skin and perhaps also gut microbiome compositions during their relevant heat exposures, and hopefully then associate those measures with other health outcomes. And again, this is going to give us some early insights into how heat affects the human microbiome, hopefully develop some new biomarkers of heat-associated stress and disease. Importantly, add microbiome measurement and knowledge to the existing dimension, sort of high-dimensional data that we're trying to collect on some of these North Carolina populations. I'll stop there. Thanks.
Thank you, Dr. Rawls. Our next speaker is João Visconti. He is going to talk about Rural Carolina's Observatory for Heat Early Warning and Health Resilience.
I'm Visconti. I'm an associate professor of emergency medicine, global health, and biostatistics and bioinformatics. I have the pleasure to present our big idea on Rural Carolina's Observatory for Heat Early Warning and Heat Resilience. I'm representing here a large group of collaboration that came together to put this idea, in particular Jordan Clark, our climate and data scientist, working with us at the Climate and Global Health Initiative, the Climate and Global Health Initiative folks, along with emergency medicine and other institutions, and their associated state partners in this proposal. This big idea stems from the existing work on the rural heat, on heat warning challenges overall, and it leverages work from North Carolina, which was one of the first states to implement a heat warning system that is tied to health outcomes, identifying thresholds for heat warning that are linked to increased uses of ED and EMS. And through this work, we're able to see in North Carolina how these microregions of heat thresholds have been established and how those are used to provide guidance. However, some of the lessons learned from this activity that has been impactful and feasible is that rural communities are not very widely represented on this current warning system, especially because the data that could stem from rural communities' weather stations are not represented into the state early warning system. So the technology is there to be leveraged, but it's not yet tied. Additionally, when you think about the thresholds might be different in rural communities, the healthcare needs of these rural communities are also different, and they could be addressed in different ways when you think about public health resiliency and how we adapt mitigation and adaptation plans. So our project stems from this takeaway that to address the needs of rural communities, we need to understand better what those thresholds are and how we can create micro plans to properly plan to address this impact. So what we're planning to do with this big idea is to establish our platform, a health analytics platform that we're calling the Rural Carolina's Heat Observatory. The platform is a bidirectional platform that includes analytics and data, along with an extensive community engagement platform, creating a bidirectional pathway where we learn from the community what their needs are and what potential strategies exist, then inform those discussions with data, build analytics based on those discussions, and then discuss implementation packages for those solutions. This platform, rooted in co-designing and partnership, that includes data coming from different sources, and I see a bunch of synergy today about different initiatives that could collaborate with this big idea around heat stress, EMS and the outcomes, vulnerability outcomes, and those then through analytics, different analytics approaches to identify thresholds and to create micro-planning strategies, then lead to health-based triggered alerts, EMS and public health protocols, or even rural heat playbooks for the community awareness. This partnership currently, initially, you can see that there's an initial tag there that Jordan was very adamant that I should say that. We put together a Duke team of different entities that were very eager to engage with other entities and people interested in the space, along with community and local partners, including local emergency management systems, public health officials, community and faith-based organizations, and also state partners that are equally engaged on this proposal. What we will build from this, and these are our work streams, is one, to generate these rural health-based thresholds. These are discovery elements, and identify what those triggers are, how different they are, and how we can make localized decisions. From that, our second work stream is then creating microplans, EMS, and public health protocols. These are resource development work stream. In this work stream, we're going to use the methodology of microplans, a widely used methodology to do public health campaign delivery, especially for vaccination and immunization. It talks about a bottom-up planning for what kind of resources, where, when, by who, planning that into a technology using system dynamics that allows us to simulate scenarios and then implement scenarios that are could effectively impact mitigation plans and adaptation plans. Then finally, through this understanding of scenarios and interventions to be built, we then can create community awareness materials through rural heat health playbooks that provide concise guide for roles, how to react to these triggers, what kind of communications are needed, and how we can continuously review this and update this. As an example, we're all dealing with a warning about what's going to happen this weekend, kind of know what to do. What are the thresholds and what do you do in heat scenarios? That's kind of where we're trying to get at. This in a platform of co-designing with these partners, and throughout the process using implementation evaluation pipelines, centered user approaches, engaging with mixed methods, both with community engagement practices, implementation evaluations, and then quasi-experimental studies. To end this presentation, besides focusing on heat and rural scenarios, this is also a project that will allow us to create a platform that can then be translated to other weather events and other sites, both locally and globally, in the same platform.
Thank you so much. All right, our next speaker is Dr. Kate Webb. She's going to talk about trauma recovery in a changing climate, impacts of extreme heat and air pollution on biological risk for PTSD.
And thanks for the invitation to be here today. My name is Kate Webb. I'm an assistant professor in psychiatry. You know that trauma exposure is a near universal experience. Each year, over 32 million individuals will experience a traumatic event that requires some form of medical care. The good news is the majority of trauma survivors recover and resume typical emotional and however, up to 20% will go on to develop post-traumatic stress disorder or PTSD. At an annual economic cost of $20,000 per patient, earlier identification of trauma survivors at risk for PTSD and therefore earlier delivery of preventative interventions could substantially reduce both individual suffering and broader societal costs. But PTSD risk assessment is challenging due to heterogeneity in environmental and biological risk factors. One thing I want to note about PTSD is that we actually know the cause of the disorder. A trauma has to occur, giving us the ability to look at environmental exposures in a more causal and mechanistic way. With that being said, climate change is actually intensifying risk factors, including air pollution, particularly pollutant PM2.5, and extreme heat that are known contributors to mental health risk. However, in trauma research, these exposures are really overlooked despite the ability of them to shape PTSD susceptibility through biological patterns. You know from now several decades of work that early signs of PTSD include alterations in neurobiology of regions involved in stress and threat processing, as well as heightened inflammatory profiles in the acute aftermath of trauma. Extreme heat, as well as PM2.5, can trigger inflammatory cascades and affect neurobiology. In fact, some of the brain regions that are most commonly implicated in PTSD, like the prefrontal cortex, are especially vulnerable to environmental insults. Together, there's converging lines of research that suggest that PM2.5 and extreme heat might be associated with PTSD onset and symptom severity and also contribute to biological susceptibility for the condition. The work so far on climate-related exposures and trauma has been limited and has pretty critical shortcomings. So the status quo measurement, which was talked about previously, is to estimate essentially all of our exposures based off of a single regional monitor at RDU. And so to address some of these limitations, we propose to leverage expertise across Duke and integrate emerging technologies in personal environmental monitoring and psychological monitoring with biomarker data from recent trauma survivors. We hope to test two aims. One, does real-time exposure to PM2.5 and extreme heat influence real-time mental health in the days and weeks following a traumatic event? And are these exposures associated with systemic inflammation or altered brain activity? To test these aims, we plan to enroll around 120 recent trauma survivors from local emergency departments. They'll complete 1 month of continuous geolocated environmental monitoring alongside smartphone-based assessments. For the continuous environmental monitoring, we hope to use the AirBeam monitor, which is a commercially available and highly accurate personal monitor that's currently actually being used in a number of citizen science projects across the Carolinas. Following this period, a subset of participants will come back and undergo neuroimaging while completing a threat processing task and provide a blood specimen that we can use to assay inflammatory markers. Notably, our research team has the experience and the infrastructure to recruit and retain trauma survivors during this particularly sensitive time. And ultimately, we expect that we might see real-time spikes in PM2.5 and persistently high temperatures that are associated with subsequent increases in mental health symptoms, and that they will be associated with greater neural threat reactivity and heightened inflammatory profiles. In addition to kind of the traditional research process and outcomes, we have 4 additional deliverables. One at the beginning, we're hoping to hold community studio sessions in collaboration with the Duke CTSI CHeRI, which would bring together stakeholders and ask about their lived experiences with these environmental exposures, clarify how they want to receive exposure data, if they want to receive it on the app or from us, and then also discuss feasibility of several exposure mitigation strategies. Out of this, the development of new community advisory board with expertise in community mental health, citizen science, and environmental justice that will help provide feedback on this project, but also develop new projects. Second, we hope to contribute all the aggregate data to the Duke CTSI Seed Health Atlas that we heard about earlier. Third, right now, all emergency departments require some level of social determinants of health screening. It's typically at the individual level, asking about housing insecurity, food insecurity. So we'll work with our emergency medicine collaborators to evaluate whether adding geolocated environmental information could be helpful in screening for risk for poor trauma outcomes and inform clinical decision making. And then finally, there's been a lot of talk about exposure mitigation toolkits, and we're hoping to develop one that is specifically targeting these kind of acute stage of post-trauma period, and for both the trauma survivors and their healthcare providers to help guide exposure mitigation strategies in the initial aftermath. Thank you very much. I look forward to table discussions and would love to collaborate further on this project.
Thank you, Dr. Webb. And so now we're going to move to the trainee track. So first off, kudos to the individuals who put in proposals. It's really daunting to do this, and so we really appreciate the individuals putting themselves out there. But each of them is also going to give their pitch. So the first one is Sashki Chopra. I hope I didn't butcher that name. I'm sorry if I did. On mapping melanoma vulnerability in North Carolina, the link between UV exposure, temperature, and geographic risk.
Hi, thank you all so much for the opportunity to present today. My name is Sakshi Chopra. I'm a third-year medical student here at Duke, and this project was created under the guidance of my research mentor, Dr. Michelle Pavlos with the Department of Dermatology. We also just want to thank Drs. William Pan and Kate Hoffman with the Nicholas School of the Environment, as well as the Climate and Population Health Working Group for their support of this proposal. So, despite advancements in both the early detection and treatment of melanoma, it remains a significant threat to our state's public health. Incidence continues to rise each year, particularly in the non-Hispanic white patient population, and it's rising unequally with significant geographic variation across our state, as you can see here. At the same time, minority patients in particular have shown increasing melanoma-specific mortality over the past 2 decades here in North Carolina. Still, there's much we don't know about melanoma as a disease, specifically how climate factors at the local and hyperlocal levels, including UV exposure and pollution and heat, can impact patient risk. There was a study that was recently conducted on a national scale using climate data at the county level to identify hotspots for skin cancer. And our idea is kind of derivative of that study. However, Their data is not specific to melanoma, so it's generalized across all skin cancers. It doesn't provide the level of granularity that we're hoping to achieve on the state level to really make a difference for our patients. And it also excludes minority populations, we believe are a key part of the picture. Because of these knowledge gaps, and particularly given that dermatology as a field has such limited resources, it remains challenging for us to target our interventions to the patients in greatest need of support, primarily because we don't really know who those patients are. So the solution that we propose to this end is the development of a climate-informed melanoma-specific vulnerability index that helps to map the spatial clustering of melanoma across North Carolina, specifically focusing on late-stage disease. This index will consider data that spans 3 factors. So we're looking at tumor-specific data like Breslow depth and staging, population data like age, rurality, socioeconomic status, and both of those we're currently working to obtain through the North Carolina Cancer Registry. And then we're also interested in looking at climate-specific factors, which is where this kind of ties in to today's symposium. Taken together, this data will help inform the development of a tool that we believe will help us guide our identification of key geographic hotspots for intervention in the state. So after we identify these hotspots, our main deliverable will be to launch a melanoma resource toolkit that will ideally help to increase education and resource availability for both patients and providers here in North Carolina. On the provider side, which is where we're hoping to mainly focus our interventions, we propose increasing dermoscopy training among primary care providers in high-risk areas. So dermoscopy is a technique that allows providers to detect pigmented lesions early and be able to differentiate between benign and malignant lesions. And so that's the main intervention that we're hoping we can target towards these hotspots once identified through this vulnerability index to make the biggest difference possible for our patients. And then also on the patient side, we would love to implement educational workshops and the distribution materials to increase health literacy and just help educate patients in these areas about the risk between environmental exposures and their personal risk for melanoma. Thank you all for your time, and would love to answer any questions or talk more and collaborate in the future on this project.
Thank you so much. Our next speaker is Rebecca Filippo, who's going to talk about extreme heat, environmental vulnerability, and climate-resilient dialysis care in patients with end-stage renal disease.
I'm Rebecca Filippo. I'm a PhD student in population health sciences. And today we've heard a lot about the impact of extreme heat on our health and specifically the impact of extreme heat on our kidneys. But what about what happens when our kidneys are no longer functioning? Across the U.S., over 500,000 patients are on in-clinic hemodialysis for end-stage renal disease. They're already a very sick population at baseline with increased risk of cardiac events, strict fluid restrictions, and then present with frequent comorbidities like cardiovascular disease and diabetes that can amplify the heat-related harm that we make. Unfortunately, they're also required to attend thrice-weekly dialysis sessions, which means they're not able to implement those protective behavioral strategies that we may want to see. And so health systems have to be really prepared for these patients and able to target who is most at risk and who and direct those mitigation strategies. But the problem is that we don't actually know how to quantify this risk very well right now. We don't know who's most at risk, so what susceptibility factors matter, which outcomes are most affected and when, and then where does this risk cluster at the neighborhood level. So without this evidence, we can't adequately protect this population as extreme heat events increase in frequency and intensity. So our proposed study will generate this urgently needed evidence by combining United States Renal Data System data and high-resolution climate and environmental data sets within a causal framework through 3 strategic aims. The first is to quantify the causal impact of extreme heat events on hospitalization and mortality and be able to identify who is most at risk or which outcomes are most affected and when after an exposure to extreme heat that vulnerability increases. The second is to look at patient susceptibility factors, so comorbidity status, treatment level factors that may amplify this risk in order to inform the development of a clinical vulnerability index. And then lastly, combining environmental neighborhood level factors such as urban heat islands, land use metrics, and socioeconomic data to create an interactive dashboard so that people can identify which neighborhoods are actually at highest risk. The goal is to deliver usable tools to health systems that they can implement to really direct resources and create climate-informed dialysis care. As extreme heat becomes our new normal, we have an obligation to protect those most at risk. The goal of this project is to create the evidence needed in order to prevent those preventable hospitalizations and deaths, increase climate-resilient dialysis care, and then advance health equity for underserved populations who are disproportionately at harm from climate-related events. Look forward to collaborating.
Thank you. And last but not least, Sierra Smith, who's going to present on investigating the mechanisms of chronic effects of heat stress on renal development and function.
Hi, everyone, and thank you so much for the opportunity to speak here today. It's been so wonderful to hear about everyone's projects, and I'm really excited for all the potential collaborations that can come out of this. My name is Sierra Smith, and I'm a second-year PhD student in the Integrated Toxicology and Environmental Health program. And my lab is interested in studying the effects of environmental factors on kidney health and function. And my PI, Dr. Nishad Jayasundara, spoke earlier today on this topic. Through fieldwork conducted by Dr. Jayasundara in Sri Lanka, our lab has demonstrated that humans can experience core body temperature increases exceeding 2 degrees Celsius through strenuous activities such as farm labor. In the areas in which Dr. Jayasundara conducted this fieldwork, agricultural workers experience really high rates of chronic kidney disease of unknown etiology, for which heat stress has been identified as a driver. Despite this knowledge, we still do not have a basic understanding of how even small changes in core body temperature can impact kidney function in any organism. In my project, I plan to use zebrafish as a high-throughput model to examine how small changes in temperature can impact kidneys. I want to leverage their ectothermic status to allow for precise small core temperature changes that would be both costly and time-consuming to perform in mammalian model organisms. Through my experiments, I will have the ability to examine the unknown acute and chronic impacts of small temperature manipulations on different structures and functions of the kidney. I'm interested in how these small temperature changes can impact toxicokinetics in the kidney and change physiological responses to other environmental stressors as well. Of particular interest to me is examining the molecular pathways through which heat can impact kidneys and seeing if these pathways overlap with those known to be acted upon by chemical stressors. This would help us better predict how heat can modulate the effects of toxic chemical exposures that, as was discussed previously today, can often occur in tandem with heat stress. Uncovering the basic biological mechanisms through which temperature changes can impact kidneys will provide an essential foundation for examining how heat interacts with critical developmental processes and which cellular processes are vulnerable to heat. Additionally, understanding the molecular pathways heat acts on will help us prioritize research on chemical stressors that act on similar pathways. With the advent of climate change, it is more important than ever to understand how heat impacts basic biological processes. And with the data I collect through this project, I hope to get us one step closer to this understanding. Thank you.
Now a bit of just wrapping up, and you all are definitely the warriors of this population because you've maintained yourself for the whole day, which is way beyond Catherine and my attention span. So kudos. We certainly would love your feedback. We want to, this is the first of several, so we're planning to do this annually as a part of the funding from the Duke Endowment and hopefully going into the future. So we'd like to make this better, and we can only do that with you guys telling us how you think it could be better, what worked, what didn't work. We'll probably also email this out because there's a larger group of people, so you'll get a chance to do that. But please fill it out. Like, even those surveys are kind of passé. And they certainly have their own bias, but the only way we make it better. And in terms of also thinking about future topics, because obviously this is the inaugural event, and we had sort of a focus on showing you what we're focused on and what we're interested in, but future events can have themes. And so we're hopeful for that to be the case. The other piece is, so now for these groups that have gotten some feedback, and hopefully that sounds like it's been useful and it's been something that will help you. Not just going to go away. You're going to hear from Catherine and myself. All of you have heard from Catherine already. Think about sort of how to help with implementation strategies for your projects. But we're also here to provide some feedback. and happy to sort of hear from you all in terms of things you're thinking about and to try to help you sort of make the best proposal possible. It'll go through a similar process that it went through with the big ideas. There'll be a review panel of people that will review that and then the decisions. And one of the things I will tell you is, the purpose of this was to make it smaller so that your hit rate was higher on getting the funding. I would say, without a doubt, every single one of you would love to fund every one of the projects. So if for some reason we come up with something where your project ultimately doesn't get funded, please don't despair. We're also trying to source other sources of funding for this as well, and so we hope to use that in the future. And I spend a lot of time with the development folks to try to organize more support for these activities. So please keep the energy going here, and we're happy to keep doing that. And there'll be some events that will occur over the course of the year to continue to do that. As another note, we are here to help you publicize your things that you're doing. So one of the advantages of having the Dean's ear is that you get access to the communications group from the Dean, and thus far they haven't told me no, so I'm still going to try to keep pushing that. We don't know if we don't know, so feel free to let us know about things. So in fact, the CLIF group, we added that in as a slide sort of on the spot. But if you have events that you think are climate and health related and want some help with publicity, we're happy to do that. Those can also be broader climate events, because I do want to continue to encourage people to think about campus. There's so many amazing people on campus that I've gotten a chance to meet, and I hope you do, that do some really wacky stuff, even things that you wouldn't think. So a woman who I met who is in theater and does puppet work, and she uses puppets to provide sort of important information, which sometimes would be controversial, but most people don't think of a puppet as controversial. So it can be controversial topics through puppets that you wouldn't think otherwise. So as an example of just things to do. There's also the website, so we'll provide information on the website. With that, happy to close, and thank you so much for your time here.